the pioneers in the field of ECMO. So we are eagerly waiting to hear from them. Before going for today's talk, just a short recap of what we learned yesterday, what the eminent speakers had shared with us yesterday. So yesterday, the first talk was on ARDS ventilation by Dr. Charan. The take-home points like two strategies do help in reducing the mortality in ARDS. The first one is low tidal volume, around 6 ml per kg, and the prone ventilation. So prone ventilation, you should try to do appropriately as early as possible when it is indicated after appropriate ventilatory management. So ECMO has a role, but not after 7 days of ventilation, that is in the late phase of ARDS. So that is short take-home message for ARDS. For COPD ventilation, always remember in mind that the respiratory rate should be low, tidal volume should be low. You should give adequate time for expiration, make the inspire time shorter, and along with ventilator settings, make sure that you medically treat the patient properly with adequate bronchodilators and treat the underlying cause like infection. And when you start with NIV, make sure that you monitor the patient properly and then try to intubate and do not hesitate to intubate if the patient fails NIV. That is one another take-home point in COPD. And the final presentation of the day yesterday was by Dr. Anup Kumar, the HFNC and its application. Definitely, so many things we learned on HFNC. The most important thing is try to keep the flow as low as possible, around 30 to 40 liters, so that the oxygen requirement doesn't go up. More the flow, unnecessarily we are ending up with increasing the oxygen flow through the machine. Thereby, we are unnecessarily wasting the oxygen. That too in times of needs like COVID pandemic. So that's about the short recap for yesterday. So going for today's first talk, I would like to I invite Dr. Sunil Pubani sir. Actually, first of all, I thank him for accepting this invitation and sparing his time to share his knowledge. A few words about him. Professor Dr. Sunil Pubani sir did his undergraduate from Cornell Medical College in 1983 and MD from PGMR Chandigarh. And he obtained CCT in Pediatric Critical Care from UK and Fellowship in Pediatric Critical Care. And he worked as Senior Consultant Pediatric Critical Care, and he underwent, So he was the past chairman of ECMO Society of India and founder chairman of South Asia, West Asia chapter of Extracorporeal Life Support Organization. And he currently works abroad. And sir, over to you, sir, on ECMO, evolution, types and applications. Over to you, sir.
Thank you very much for kind introduction. Can I share my screen, please?
Yes, sir. Yes, sir. You can share now, sir.
Yeah. Good evening, everyone. It is a pleasure to talk to you. I'm talking to you from Dubai, UAE. Let us go through few of the aspects. These are very important in the foundation of ECMO, how it has happened. And I really enjoyed going through the history of medicine, especially with respect to ECMO. It is very interesting to note the thought processes about ECMO have started in 1965 onwards by Robert Hooke. You all know Robert Hooke from his different innovations, as he was the one who made the first compound microscope and looked at the germs, and he described the cells as well at that time. The suggestions about possibility of exchanging gas started from his time onwards. Then scores of researchers continued to work on the principles, bridging stones further. Some of the very important persons are J. McLean, whom you all know as the discoverer of heparin. J was third year medical student when he discovered heparin, which has been a foundation for all of us to continue with ECMO circulation or extracorporeal circulation in the tubings outside the body. For that, an anticoagulant is very much needed. So another important person whom people don't mention usually is about Brukshanko from Russia. He was contemporary to John Gibbon, slightly prior to John Gibbon as well. Most of the experiments were on animal experiments with Brooks and Co, but he was very close to developing heart-lung mission at that time. To our right side, we see John Gibbon, who is the father of cardiopulmonary bypass technology. As ECMO also involves cardiopulmonary bypass, these are the common foundations for us in the development of cardiac surgery as well as in ECMO. And finally, to my right side is Dr. Robert Bartlett, whom we call as father of ECMO. Bob was responsible for taking up the cause of ECMO in the entire world, and he continues to lead us even today, despite his age approaching around 90 years. So this was the one of the first missions by Donald Hill, who is contemporary of Bob Bartlett. Donald was an adult surgeon. He placed this adult patient following trauma on ECMO. You can appreciate how big the oxygenator was in that room, along with ECMO consoles and other machinery next to him. From there, they have been miniaturized. This was the first successful adult ECMO patient in 1971. Then, prior to that, going back to John Gibbon, he was a cardiac surgeon. When John was working at the Johns Hopkins Hospital as a surgical fellow, he came across a case of pulmonary embolism, and the patient passed away while he was on call. So these thoughts about developing a mission for bypassing pulmonary circulation for oxygenation and for gas exchange, this continued in his mind, and he continued working on this for the next three decades on this, culminating in efforts of discovering or making this cardiopulmonary bypass mission. So after 4 years of John working on this mission, the first patient was successful, but subsequently he lost another 3 patients. At that time, Dr. Gibbon, he left his mission for using for cardiopulmonary bypass. Then from Mayo, Dr. John Kirkland and his associates joined in doing minor modifications to this mission and bringing out the new cardiopulmonary bypass mission. The mortality of cardiac surgery has declined significantly post in this invention of this mission. Regarding the ECMO pumps, we had 2 types of ECMO pumps. One is the roller pumps or the occlusive pumps. These are the ones which are used in the cardiac theaters, which all of us know. In the initial days of ECMO, we were using roller pump. Even while I was at Glenfield Hospital, Leicester, till 2005, we were using roller pumps only. These pumps will displace a volume of fluid depending on the speed of the pump and are insensitive to afterload. The other pumps are non-occlusive pumps, or rather also called as centrifugal pumps. The other varieties are diagonal and axial in the centrifugal non-occlusive pumps. These pumps are preload dependent and afterload sensitive as well. So from 2005 onwards, the world or most of the world has been concentrating on using centrifugal pumps for ECMO. There are few hospitals which do continue with roller pump ECMO, but most of the centers have switched over to centrifugal pumps. These centrifugal pumps produce a hydrodynamic pressure gradient through rotational kinetic energy through the use of an impeller assembly. So the impeller is sealed within an operating chamber and is magnetically coupled to the drive motor. So electricity is essential for converting this mechanical energy into kinetic energy. Centrifugal pump generates flow of the blood by a spinning motor which generates suction in the center inlet and then propels the blood outward from the pump housing, thus creating a positive pressure at the periphery of the pump head. And the next couple of slides will show you and explain to you a little bit more. This is the circuit diagram of ECMO. Here you can see a baby having veno arterial and venous cannula here. These can be attributed to, you know, a W-man cannula going in will look like in the same fashion also. If you chase this venous limb of the circuit here, the venous limb is here and it is going further through the return sorry, this is the pre-pump here, and from the pre-pump through the console we will manage, or we will direct how much flow is needed. From there, from the pump head, blood is going towards oxygenator. Once it is oxygenated or the gas exchange take place here, you can also see this gas, the sweep gas coming from the blender onto the oxygenator, and the oxygenated blood goes back to the body at the required temperature as helped by this heat exchanger here. The blood is going back to the arterial limb of the circuit. We don't have this bridge. Please ignore that bridge from this. But apart from that, the rest of the circuit is correct. So the components of the ECMO circuit as well as ECMO machinery is most important are console, circuit, oxygenator, heat exchanger, blender, sometimes bladder, not usually but only sometimes, and the pigtails. These are common essential components of ECMO machinery. So regarding the roller pumps, as you can see here, roller pumps run by displacement of the blood across this tubing by the mechanical force. By the electrical energy, the pump will be rotating here. This part, the front part of the tubing which goes into the console here through the roller pump, it gets displaced by the mechanical action, by the compressive action. So periodically we used to change this circuit part which is within the roller pump. This is called as a walking of the raceway, as if it is here for longer period of time due to frictional forces that can get weaker and it can rupture also. So to prevent that, we walk the raceway. The tubing is called as a raceway from time to time, depending on the flow of the blood, depending on the speed of the blood on that. So majority of the institutions have not been using roller pump these days. Sorry. Here on the right side, you can see the roller pump ECMO being on as well. It doesn't allow retrograde flow, but it provides a reliable constant flow rate. The second most important ones are the centrifugal pump. You can see a centrifugal pump here along with the pump head, which is displaceable on the top, and a cross-sectional view of the biopump plus as well. The centrifugal pump is a non-occlusive pump. It operates on the principle of entraining blood into the pump by a vortexing action of spinning impeller blades or rotating blades. Sometimes when the impeller blades are avoided, then magnetic levitation technology will help in minimizing the trauma caused to the blood as well in the most advanced machinery nowadays. Other company which is making ECMO consoles is Medtronic. It is relatively cheaper mission compared to the other missions, but the problem we come across with Medtronic is the pump head, if overused or beyond 5 to 7 days, can result in hemolysis. So whenever you see hemolysis happening, then you need to replace the pump head. So that is the downside of Medtronic. Otherwise, it's a good mission. The ones which are commonly used nowadays in the market are Mackie mission, moderately priced. The Rotaflow is the most common. Cardio Help is also available. Cardio Help is quite useful as a portable ECMO pump to be taken to anywhere else in the roadside accidents or anywhere when the patient has to be kept on ECMO. They can be cannulated, put on this simple mission, which is an integrated machinery here, including oxygenator and other pressure monitoring devices. They are all coupled together in this cardio health mission. So that is quite compact. Whereas the rotoflow is more often used on intensive care units for supporting patients on ECMO. These are from Mackie. The other manufacturers making ECMO pumps are Sorin and Centrimag, as a couple of other examples. In United Kingdom, I worked mostly with Centrimag over there. To your left side, you see the first generation Centrimag mission. Over there is electronics, and to the right side, you see the second generation Centrimag mission over here. It was initially developed to help with LVAD technology, but afterwards adopted for ECMO, and it is quite useful by minimizing hemolysis. That is a added advantage I find with Centrimag machinery. Say whenever you go for Centrimag machinery, which is reasonably costly, but it is mandatory to purchase two missions for one, because the other one is a standby for you. And in this Centimag 2 second generation one, you can also see the monitor for monitoring the flows, and other numbers also can be seen with relation to the flow dynamics on the monitor. So coming back to Mackie console here, and the Centrimag console here, battery on the Centrimag console, you can see the battery life here. Is the battery fully charged or not, and the flow in revolutions per minute and liters per minute, and other buttons which are helpful for us for altering the flow dynamics. These are all labeled in the picture. The pump head, you're seeing two components here. The Centrimag motor is the metallic one, and as the top one is the pump head. So this pump head internally, it looks like this. There's a propelling system inside. The impeller blades are there. It works by magnetic field, by magnetic levitation technology. There is a small video I would like to play.
Full maglev flow technology, only from Abbott, is designed for optimal hemocompatibility through precise rotor control and gentle blood handling. By using full maglev flow technology, a blood pump's rotor operates without bearings or seals. Instead, the rotor is levitated and controlled using electromagnetic forces, enabling precise control over rotational speed and absolute stability of position in every direction. This works by measuring the exact distance from the outer edge of the rotor to the inner wall of the motor tens of thousands of times per second, adjusting the magnetic field constantly to counteract outside forces such as gravity, bumps, and movement, maintaining stability in all 6 degrees of freedom. With no bearings or seals and precise rotor control, full maglev flow technology enables large, consistent blood pathways and smooth blood flow, which should result in minimized blood stagnation, friction, and shear stress for gentle blood handling. Full maglev flow.
So these are other pump heads in different machinery in Sorin, Mackie, Centrimag, etc. The priming volume in this will be different as well as per the sizes. The second important component is the circuit. The circuit is made of PVC, as it is the most important component here. In the days of in the days of roller pump ECMOs, the circuit length used to be longer because we had to walk the raceway over here. So after instituting centrifugal ECMO, the circuit length has significantly came down. This has major implications with respect to the pharmacodynamics, alteration of drug concentrations on ECMO circuit, uh, all these things, because the volume, the circulating volume with this tubing also will come down when the circuit size is reduced considerably. Most of the circuit tubing in ECMO is made of PVC, polyvinyl chloride, mixed with a plasticizer. The amount of plasticizer added determines the flexibility of the tubing. Currently, diethyl hexyl phthalate is used as a plasticizer to ensure ECMO circuits are flexible. The external diameters of ECMO circuit are variable. 3/8 used for adult ECMO, 1/4 for neonatal and pediatric ECMO. Half-inch tubing is also available. The efforts are on to make this circuit more and more biocompatible. It represents one of the largest surface areas and volumes for the blood contact with any other medical device. Here there are two things here which will add to the circuit surface area as well as oxygenator surface area. These two, they are significant, amounting to a volume of 75 to 250 depending on the manufacturer and size, pediatric to adult. And again with the oxygenator adding another 70 to 250 ml of volume depending on the length and diameter of the tubing. So when blood is passing through these artificial surfaces, obviously it generates systemic inflammatory response. So to minimize this systemic inflammatory response, circuit coating has been adapted with more biocompatible materials. The following are the current practices. Once you run the circuit or the prime the circuit with the albumin, this albumin pre-coat will provide a base layer of protein that would delay or mitigate the biological response to the heavily hydrophobic surfaces. The second most important element is heparin, unfractionated heparin, as it is a systemic anticoagulant. We use it for surface coating, and heparin banded circuits are also available. Several other surfaces that have been developed with the aim of increasing hydrophilicity of the surface, charge similar to that of endothelial cell lining, are also being developed. These are typically polymers including phosphoryl choline, poly-2-methoxyethyl acrylate, polyethylene oxide, and triblock surface. Other one which is still in the research is nitric oxide as a natural inhibitor of platelet activity through cyclic GMP mechanisms. So if the membrane or the inner side of the tubing releases nitric oxide, that would be one of the very effective ways of mimicking endothelium. These are various oxygenators available with coating, also biological coating or biocompatible coating to reduce adherence of platelets and to reduce the systemic inflammatory response syndrome. I'm sure you heard about the pigtails. These are the pigtails which come off from the circuit at junctions. They have got a specific name as pigtails. Here we use them for taking samples from the ECMO circuit or giving any medications or monitoring pressure at various points. So these are the pigtails. They are very important and they need attention on daily basis, multiple times on daily basis too, because as this is a area where flow fluctuations happen, blood clots can also form at this point of circuit. So one has to be very careful with that. The next one is on cannulae. Cannulae are extremely important. They tend to vary depending on the size of the patient. It could be a neonate, infant, a child, adolescent, or an adult. massive cannulas in adults compared to the size of the babies. WMN cannulas like Avalon cannulas are available ranging from 13 French to 32 French, depending on the age. There are nomograms from which you can choose your cannula, and it comes with a separate package for serial dilatation of the vessel and introduction of the vessel. Usually the venous cannula will have multiple side holes, whereas arterial cannula will have side holes, end holes only, as you are reinfusing blood back into the body here. It is very important, like these cannulae should be metallic reinforced, so that they won't collapse on themselves. They have a thin, flexible plastic outer layer which permits curving but prevents kinking. Cannula are very susceptible to puncture, so one has to be very careful not to approach them with any sharp instruments. Distal reperfusion cannula is very important in case of veno-arterial ECMO, especially the lower limb vasculature is used. So whenever you are using the femoral artery, antegrade blood supply to the limb should be continued by using distal perfusion cannula, which are usually either a 6 French, 7 French or 8 French cannula. The flow of the blood ranges from 100 to 150 cc per minute. So this is very important to preserve the integrity of the lower limb without any doubt. Oxygenators are the gas exchange units for us. We started with silicon oxygenators before, and the ones which you have seen with the patient used in Dr. Donald Hill's time in 1971. So massive ones. From there, they became so compact, like the one which you are seeing here, the Mackey quadrox oxygenator here, which is one of the best oxygenators. These are other types of oxygenators available as well. They are interchangeable on your ECMO circuits. Whenever oxygenator fails, then you have to change it to a new oxygenator. Be mindful of clots in the oxygenator. So these are Paragon as well as Meadows oxygenators. Some of them like this will come with integrated circuit for heat exchanger also. The new oxygenators are made from PMP, polymethyl pentane, hollow fibers. They contain an integrated heat exchanger. They're designed in order to reduce the formation of micro bubbles and protect against the bacterial contamination. They have low pressure drop across the fiber bundle and a small priming volume of 252 ml. These are most efficient. For me, they used to last up to 60 days also, though the manufacturer's recommendation is up to 14 days. Heat exchanger, this is for regulating the blood, usually to keep it as a normothermia, but even if you want to cool the patients as well, you can cool to provide them in hypothermia settings. Ultrasonic flow sensors are very important. Despite the fact we generate the flow using ECMO consoles, because the flow on centrifugal pumps depends on preload as well as afterload sensitivity. So to know exactly how much is the flow that we are achieving, these ultrasound flow sensors are important to tell us what is the exact flow that is being delivered to the patient. Circuit clamps are important as well. Whenever we are changing oxygenator or cutting the tubing secondary to clots or something, you have to replace a pigtail, for example, or for changing oxygenators for these things. It is very important to clamp the circuit with specially designed circuit clamps, and at times you may need a scissors as well to cut the circuit from the blind end. So these are the other connections you need, like the Y connector or arterial cannula, perfusion adapters. They are also needed with that. They are extremely important in your ECMO kit. So Secrist oxygen blender, like the ones which we use in the ventilator, no difference to that. You can regulate the percentage of the oxygen you are giving to your patient. bubble detectors are also available on placement in some ventilators. So some ECMO machines, they are integrated, but in others they are available also. So lastly, for regulating the flow through the tubings, you need clamps. These are called Hoffman clamp. So you can regulate how much blood you are allowed to go through that without flooding one particular circulation or other. So regarding ECMO circuitry components, it is a dynamic evolution phase, and it will continue to do this because we are looking for more and more biocompatible components to replace the existing components. These are essential for us to make it more patient friendly, reduce the systemic inflammatory response, reduce the platelet damage, etc. And hemolysis too. Research is on. We talked about nitric oxide delivering to circuit tubings, which would be available in future time, mimicking the endothelium. And coming from a developing country or a resource limited country, I also stress the need for manufacturing oxygenators, cannulae, and ECMO consoles indigenously so that the cost of these components will come down as well. Thank you very much for patient listening. This is my first talk. Now I will proceed to my second talk. My second talk is on types of ECMO evolution and the components. The types of ECMO. Basically, I would like to describe the types of ECMO as four different types. One is the veno arterial ECMO and veno venous ECMO. These are the standard types of ECMO.
Sir?
My colleagues will be talking on, my colleagues will be talking on veno arterial ECMO and veno ECMO. So I won't be expanding on them. What it means is you drop. I'm sorry.
Sir, are you able to hear me, sir?
Yes, I can.
Sir, actually, your screen is frozen, sir. We are not able to see the next presentation, sir. It is hanged up in the previous presentation, last slides.
Okay. So, shall I stop share and then go back?
Yes, sir. Yes, sir. Please, sir. Yes, sir.
Sorry for that.
Yes, sir.
Is it visible now?
Yes, sir. Yes, sir.
Yeah. Thanks. Thanks for correcting. So I'll be dealing with the four basic types of ECMO: veno arterial ECMO, veno venous ECMO. My colleagues will be talking in detail about them. Veno arterial ECMO is you collect blood from a vein and infuse it into an artery, whereas veno venous ECMO is you drain the blood from venous source and infuse oxygenated blood back into venous source. That is veno venous ECMO. And moving on from there, the variation from the VV ECMO cannulocytes. These are like hybrid ECMOs. These are the next types. As we are understanding ECMO more and more, people are concentrating on provision of hybrid modes of ECMO in selective cases, not in all the cases. The primary modalities of ECMO should be veno venous or veno arterial, depending on primary respiratory support or respiratory plus cardiac support or primarily cardiac support. But in particular scenarios, we might think about going for hybrid cannulation technology as well. And the last one I would like to mention is about the central cannulation for veno arterial ECMO. These pictures will tell you exactly what we mean by that. As we mentioned about the veno venous ECMO, draining from venous source and infusing back into another venous source. VA is draining from the venous source and infusing it into an artery, femoral artery. In this case here, these are the hybrid circuits here. In addition to the veno venous, if you have to reinfuse arterial blood into a venous source, that could be one of the modalities. And similarly, you can see a VVA ECMO over here. So draining blood from a vein and from another vein and combining them together via Y connector, and this blood is drained and sent to the oxygenator, and the oxygenated blood is going back to femoral artery here. So when you need extra blood to be circulating through your through the circuit, then we tend to resort to these sort of hybrid modalities. There is other thing called as parallel circuits also. This is useful in cases of sepsis, for example. When there is a hyperdynamic circulatory state, the volume of the blood needed by the body for keeping the tissues oxygen rich or infusing oxygen into the tissues will need more than what the circuit can offer. So in those cases, two separate ECMO pumps can be run with two different consoles also. Is a parallel VV ECMO, and you can also see similarly parallel VA ECMO also. Another example is when there is a pulmonary edema as a result of left heart dilatation. That is another example to resort to that. Some of the other modalities are coming up, such as Protect DO. These are the preferred modalities for patients with combined respiratory failure with right ventricular failure here. Here, you suck blood from the right atrium and infuse blood back straight away into the pulmonary artery. So from there, it bypasses and it goes to the circulation from there. So these are other modalities I would like to mention briefly about the types of ECMO. Central ECMO, a word about it, in neonates or in adult cardiac patients, once following cardiotomy, and if the patients need prolonged cardiopulmonary bypass, or even after coming off from the bypass, they need to go back onto ECMO circuit. In those cases, it is ideal to keep them back on central ECMO by reversing back onto by reopening the sternotomy, which has just been done, and you can cannulate this way. And the cannulae are usually the specialized surgical cannulae. Axis cannula is the wire reinforced and malleable and is sited within the right atrium via the right atrial appendage. It can be tunneled out of the chest, and the sternum is closed, as you are seeing in this picture here. The return cannula is a Dacron tip and sewn directly into the proximal aorta. The cannula is then tunneled out of the chest and the sternum is closed here. If the chest is open, we tend to keep central ECMO for nearly 72 hours. See how the patient is doing afterwards. If the patient still needs support of ECMO, then we convert it into peripheral ECMO, or this modality you can close the sternum while keeping just two openings here. With this, you can run the ECMO for 2 weeks in this case. But there is a possibility of increase in bleeding here and a possibility of infection compared to peripheral veno-arterial ECMO. Let us briefly mention about development of ECMO. I mentioned about how the thoughts have become prospering from 1665 days after Robert Hooke proposed the possibility of a gas exchange by artificial means. From that time onwards, several researchers continued to work for centuries together, and they culminated in John Gibbon began investigating into this use of extracorporeal oxygenation following his experience of losing a patient with the pulmonary embolism while he was a surgical fellow at Johns Hopkins. So his initial experiments on animals ended with 3 cats out of 39 cats survived for a period of 1 year following 2 hours of cardiopulmonary bypass in his indigenously made cardiopulmonary bypass circuit. The difference between John Gibbon and his previous researchers was the previous ones really they were working with experimental animals, cats and dogs, etc. While and pigs also. While John Gibbon was the first one to go on to onto human experiments. Certainly, John Gibbon and others were helped by J. McLean as a second-year medical student who discovered heparin at John Hopkins. And this has been a bliss for all of us to make sure blood doesn't clot while it is flowing through the artificial membranes. So here is John Gibbon and his initial research associate Mary Gibbon, who later became his life partner, and they were working on heart-lung mission. In 1953, ending his 23 long years of apparatus designs and experimentation, Dr. Gibbon performed first AST repair, and this was the girl. She did remarkably well. Afterwards, he lost the next three patients, and he abandoned his further use of a heart-lung mission. Then the Mayo Clinic asked for the plans of his oxygenator. They worked together. They developed a Mayo Gibbon type of oxygenator with Dr. Coughlin and his team collaborating with John Gibbon. The mortality rate for intracardiac surgery dropped from 50% in 1955 to 20% in the next year and to 10% in 57. So you can see year by year, there was significant decline in the mortality following intracardiac surgery. Lot of attributes to Dr. Lilihi as well. He was a cardiac surgeon too. He performed surgery via cross circulation using parents and children, and also a bubble oxygenator he invented along with Richard Dewall in 1954. It was the generation of further developments of oxygenators. More and more biocompatible oxygenators were made from the technology they knew at that point of time. Initially, the bubble oxygenators, which were useful only for an hour or two at a time, to silicon rubber oxygenator, which was used for prolonged periods of time. Bubble oxygenators had certain disadvantages of thrombocytopenia, coagulopathy, hemolysis, edema, etc. And Colabo and Dr. Japal, they worked on a spiral coil membrane oxygenator, which helped in miniaturizing the size of the membrane oxygenator. The silicon membrane oxygenator didn't have an air gap in interface. This was useful for weeks to months together. It was limited by diffusion of oxygen through the blood. Semi-porous hollow fiber oxygenators were the next generation ones. Gas flows through the membranes. We are seeing a modification of this generation of oxygenators now. They are very efficient. We do see plasma leak across the fibers now and then, but there are ways you can come over that. Non-porous oxygenators, they are also available with minimal hemolysis. So those were the few bits about oxygenator. The current ones which we are using are polymethyl pentane oxygenators, are the PMP oxygenators. Credit will be given to Dr. Donald Hill for his first prolonged cardiopulmonary circuit as ECMO circuit for 75 hours outside the cardiac theater in 1972. And this was the patient following road trauma. He was on ECMO and he did survive in 1971. Then came the era of Bob Bartlett. In 1972, Bob helped in operating on a patient on mustard procedure. And then in 1975 was the historical case of meconium aspiration syndrome on Esperanza. Esperanza was a little girl whose mother was a Mexican. She passed the border illegally and came to the place where John was working, and she delivered over there. This little girl, she had meconium aspiration resulting in hypoxia. She was tried on various modalities of ventilation available over there. As this hypoxia was irreversible, she was put on ECMO pump for the first time by Dr. Robert Bartlett. She was named Esperanza by the doctors, by the nurses there. In Spanish, Esperanza means hope. So Esperanza remains as a hope to ECMO community, and this was her picture on his 21st birthday. Even when we go to US conferences, Esperanza comes over there to meet us. Dr. Schwanberger, he is mainly responsible for the development of double-human Avalon cannula, which was revolutionary. This is a single human cannula, single cannula with two lumens in it. One is an arterial and other is a venous side incorporated in a single lumen. That's why it's called the double lumen cannula. It reduced the recirculation rate to 2%. That is remarkable, and it is useful for from 3 months to 75, 80 years, whatever age you want to put patients on ECMO for venous ECMO purposes. This was the first picture of ELSO when Dr. Bartlett and his team organized it in 1989 at Ann Arbor, Michigan, and this place remains as a center for ECMO for the worldwide community. Roller pump ECMO circuit diagram over here. Two oxygenators are connected in parallel over here, and you can also see walking of the raceway. Here, this part of the ECMO tubing is taken off while the pump is stopped and patient is supported by means of ventilation, inotropes, etc. as needed for the duration. In experienced hands, this doesn't last for more than few seconds. So this used to be a routine for us while we were working on the roller pump ECMO till 2005. So this is another example of roller pump ECMO on a neonate in 1999. Regarding the studies, I'll mention very briefly about a few of the very important studies, randomized control trials proving ECMO. We learned a lot of lessons from NIH trial in USA done in mid-70s. Entry criteria were PaO2 of less than 50 millimeters of mercury on 100% oxygen. But the problem here was the conventional as well as ECMO group death rate was near 90%. The problems with the NIH trial were some centers had no prior experience of ECMO before participating in this NIH trial. Best and worst patients were excluded. It was a time of influenza pandemic, and excessive bleeding of more than 2000 ml per day were also noticed in this. Anticoagulation policies were not very well determined at the time, and lung rest was not used as well. So with all these problems, NIH trial was a negative trial, as the mortality rate in ECMO limb was 90% as compared to the conventional limb, which was also 90%. People felt this is the death of ECMO, but still two groups of researchers continued to maintain their interest in the NIH trial. One of them was Bob Bartlett's trial in the neonates. They continued to put patients on ECMO. Bob practiced a few cases per month, and in 1986 there were 18 centers in the USA doing neonatal ECMO. By 1981, they treated 45 newborns with a success of over 50%, and it led to the establishment of more ECMO centers. By 86, 715 neonatal cases were reported at 18 centers with favorable success rates of about 80%, which is a significant improvement from 50% in 1981. But with respect to the UK, we needed another randomized control trial over there, as the funding depended on proving the success rate of ECMO over conventional methodologies and the superiority of ECMO over these methodologies. So at that time, Dr. Richard Formin established ECMO center in Glenfield Hospital, Leicester. And that was one of the 4 ECMO centers working over there, which was about to close down due to funding issues. It was raised in the parliament and it got funding for the UK collaborative neonatal ECMO trial was started at this time with 4 centers. And this is a positive trial, hugely positive. 185 patients were recruited to this trial, 93 in the ECMO limb and 92 in the conventional limb. With ECMO limb, the baby surviving, 63 babies survived up to 1 year, whereas in the conventional limb, 37 babies only survived to 1 year. So post ECMO analysis continued for 5 years and 10 years after this trial also. Glenfield Hospital in Leicester, UK maintained faith in ECMO as such, and they treated cases of adult ECMO as well. They used to host meetings of ECMO survivors yearly. Survivors used to come back and share their experiences. From 2005 onwards, there was change in equipment, centrifugal pumps, PMP oxygenators, proning technologies, importance of physiotherapy, and further innovations for biocompatible circuits and material became more and more accessible. So Bob Bartlett calls this period as ECMO 2. At this time, at Glenfield Hospital as a center, we started doing CSER trial. CSER stands for conventional ventilation versus ECMO for severe adult respiratory distress syndrome. This was an adult trial. 180 patients were recruited from 68 centers over a 5-year period from 2001 to 2006. This was a successful trial, but unfortunately, while we were analyzing the cases, not only the survivors on ECMO, but even those conventionally managed patients on ECMO principles were added to the survival figures. So that is a criticism about the CSER trial. Relative risk reduction was in favor of ECMO here, but in view of mixing this conventionally managed patients on ECMO principles with their survival rate attributing as a ECMO success rate as well, there were some questions raised following this study, but certainly adult ECMO importance has grown following CSER trial. To verify the problems following the CSER trial, OLIA trial was taken up by Dr. Alan Coombe et al. With France as the center. Very strictly criteria were managed here. At 60 days, 35% in the ECMO group and 46% in control group died, showing a relative risk of 0.76. So more number of patients died in the control group compared to ECMO group, but this didn't reach the required confidence levels to say ECMO is definitely useful. This is because some of the patients who were in the control group were recruited to ECMO limb when death was certain, and they were rapidly deteriorating in those cases. So there was a mix again with ECMO cases and those who were conventionally managed earlier on and later on converted to ECMO as well. With that, the confidence intervals were not statistically significant, but closely analyzing, this was a positive trial as well. So summarizing, first adult ECMO was in 1971-72, and first neonatal ECMO, respiratory ECMO was in 75. NIH trial, as we learned from them, when you don't have any selective criteria, there will not be any survival benefit as well. Hence, the selection criteria for the ECMO have come up. There were further trials, significantly 1990s neonatal ECMO trial, CSER trial, H1N1 pandemic, OLIA trial, COVID pandemic. They all taught us huge lessons in the world, signifying the importance of adult ECMO in saving lives. During COVID period, many countries have resorted to adult ECMO. Artificial lungs as the next technology is in the development. This is for prolonged ECMO. Very briefly about my experience with ECMO. My first case of neonatal ECMO was when I was at the Pennsylvania Hospital in Philadelphia in 1989. But from 1999 onwards, ECMO became part of my traditional life, professional life with in UK, Canada, and India. This is the picture when I was the founder chairman of SWACLSO. I conducted the first international conference of SWACLSO in Hyderabad at that time. We always stand on the shoulders of Star Wars like John Gibbon, Lily, Bob Bartlett, and my mentor Richard Foreman. So they taught a lot with the graciousness of these kind people. ECMO has spread to rest of the world today, and people are able to enjoy the fruits of it. This was how ECMO used to look like in 1999 when I started at Glenfield Hospital. Huge machinery on a roller pump ECMO with CRRT machine there and a high frequency oscillator there, heater, cooler units and a roller pump, etc. Everything got miniaturized with the technical advances, smaller oxygenators, smaller ECMO pumps, smaller consoles, etc. And so, as Bob Bartlett says, the period of ECMO 1 was up to 2005 and ECMO 2 is after 2005. There are significant differences between the two with respect to development of the equipment as well as the management technology too. ECMO in the present, miniaturized missions as we talked through in my earlier talk. The best compact efficient oxygenator, Quadrax oxygenator, which is an excellent one, heparin coated with less of complications. Miniaturized circuits are also available, which brought down the importance of pharmacokinetics and drug monitoring while an ECMO. It is important, but compared to the days when we run roller pump ECMO, nowadays it is less important comparatively. Future of ECMO in India, from ECMO Society of India, me and my friends as a collective workforce have our dreams for developing cost-effective ECMO in India. We started with very few ECMOs in the country. Today, more than 1,500 ECMOs are being done. Mostly in the days of COVID days, the entire world, including the most of India, has seen importance of ECMO. But our suggestions and work will be towards developing cost-effective ECMO, where it should be made available for middle income group people as well, and for improving the transport facilities across different states. Insurance policy should start endorsing it. It is part of the critical care, but we need to bring insurance policies awareness about endorsing ECMO as part of the high-end treatment. Locally made cannulae, new design technology, oxygenators and consoles, they are very important as well. And centralized care will help in development of expertise in expert centers, because if you do anything less than 20 ECMOs per year, you are not going to keep up your skills. So for that reason, the center should have adequate number of cases. New ECMO pump systems are being developed as well as more biocompatible systems. Adding direct thrombin inhibitors such as argatroban to the ECMO circuit coated with the nitric oxide releasing material further improve the coagulation process in a rabbit model. So they are developing technologies which will make ECMO more biocompatible. Tissue engineering techniques are also being looked at, and nitric oxide releasing polymers into ECMO circuit. We talked about that. Looking forwards for this research methodology to be available for us as part of the translation medicine in near future. Lot of progress has been made in the technological advances, and the progress continues. In year 2007, there were only Medtronics in ECMO market in India, but today other companies have also got their products. This has improved the technology from roller pump to centrifugal pumps available to the cannula need to improve further. And PMP oxygenators, we are importing them currently. If they're indigenously made, the cost should come down further. With regenerative medicine and usage of stem cell technology in helping the lungs to regenerate further for the lung recovery. I think it should be possible in future. We all look forward to developing further effective ways of improving lung regeneration in future. The future is bright. Reach the needy by cutting the cost further. Innovations are needed, expertise and training, quality control, maintenance, more and more publications to share our data is truly important. Research and keeping the ELSO membership is important to learn as well. Just these are few of our cases from Krishna Institute of Medical Sciences. A child on awake ECMO, and you can see how intentively she has been watching and coordinating with the family. This is an adult on awake ECMO. So the future is bright. I end here. Whenever you are ready, I'm happy to take questions. Thank you very much for patient listening. Over to you.
So thanks a lot, sir. Thanks for that wonderful talk, sir. Actually, in the chat box, usually we receive queries. Today, we have received a word of appreciation from Dr. Sundaram from Chennai, Tamil Nadu, sir. He had told like adult ECMO survivors speak super, sir. Gives hope and energy to learn more and practice better in this area. Excellent talk, sir.
Thank you. Thank you very much.
Yes, sir. Actually, ECMO being very novice to most of the listeners like me. So I don't think I'm going to receive any questions in the chat box. So once again, I thanks a lot for your time and the knowledge sharing, sir. Thanks a lot for joining us, sir. Thank you, sir.
Thank you.
Thank you, sir.
Okay.
So that's about basics of ECMO and evolution of ECMO in detail by Dr. Professor Sunil Pubani, sir. So moving on to next talk, Dr. Madan Kumar. He is going to talk on VA ECMO. So his current designation is he is Senior Consultant Cardiothoracic ECMO VAD and Transplantation Unit in Apollo Hospitals. And area of interest, ECMO transplantation and VAD. To his credit, he has performed more than 300 ECMOs, and results of those ECMOs are on par with international standards. And he is Honorary Professor in AHER and teacher and trainer in ECMO Society of India, Joint Secretary of the same, and member of ELSO and member of ISHLT. And he has various national and international publications in various journals. Over to you, sir, on VA ECMO. Dr. Madan, sir.
Good evening, everybody. Can you hear me?
Yes, sir. We are able to see your screen also, sir. Yes, slides are visible, sir.
So first, I would like to thank Nishant for giving me an opportunity to present here. And the topic I'm going to discuss is about VA ECMO. So on left-hand side is the Hatfield Hospital, London, where I got trained, and right-hand side is the Apollo Hospital, Chennai, where I'm practicing ECMO now. Contents of my talk will be on the introduction, indication, contraindication, vascular access with our own examples, management, weaning, decandidation, results, and summary. ECMO is basically to support the heart failure and also the heart and lung failure, combination of these two. And this is not new here, as Dr. Sunil Pubani said, it is there from 1970s. First successful VA ECMO for cardiogenic shock was done in 1973. So after that, as Sir said, there are a lot of evolution, and the technology has developed so much so that we can perform ECMO nowadays with lesser complications. This is a VA ECMO where we suck the blood from venous system and then give back to the arterial system. So any blood before the pump is any pressure measured before the pump is called as pre-pump pressure. Any pressure measured before the oxygenator is called as pre-oxygenated pressure, and post-membrane pressure is the pressure measured after the oxygenator. I'll describe about this thing in detail in maintenance. ECMO is only a temporary support. This is a very important message to our listeners. So it is only a temporary support. Either it will be a VV or a VA ECMO. It can either be a bridge to recovery, or else as a bridge to transplantation or VAD, or else it can be initiated as a bridge to decision making, especially while we are doing ECPR. VECMO indications when the patient is in circulatory shock with high inotropic requirements and significant cardiac dysfunction. So when these things are there, when we have to assess the tissue perfusion, and if the hemodynamics are relatively stable, like with reasonable heart rate, blood pressure, and CVP and PCWP, and also lactate is stable and urine output is reasonably all right, we can monitor. But when the hemodynamic deteriorates and also the lactate urine output, this is the time you need to intervene with the VECMO. This is very crucial. Once it has deteriorated a lot and sets multi-organ dysfunction, then there is no point in initiating a VECMO because the mortality and morbidity is too high. So when the patient deteriorating, in spite of all the conventional medications, then that's the time we need to intervene with the VECMO. Also, when we are not able to come off bypass machine during any cardiac procedures, we need to consider VECMO. Also in high-risk cath lab procedures like stenting the left main artery, or else in high-risk electrophysiological procedures, we need to consider this, or else during ECP also VECMO is initiated. This will be dealt in detail by my friend Dr. Arpan Chakrabarti. Etiology being myocardial infarction, cardiomyopathy, poisoning, like snakebite poisoning or amlodipine or arterial poisoning, myocarditis, especially the viral myocarditis, post-heart transplantation, especially primary graft dysfunction, acute pulmonary embolism, or else in neonates, even in respiratory condition like meconium aspiration, other things, ECMO is needed because drainage is not proper in neonates and children's of less than say 5 kg. Contraindications for VECMO is like any other any other ECMO, irrecoverable heart or lung without an option for transplantation, grossly abnormal coagulation, known severe brain damage, poor life expectancy like disseminated malignancy or chronic multi-organ dysfunction, complaints like both psychiatric or financial issues. The contraindication specific to VECMO is the patient is going to have significant aortic regurgitation or aortic dissection. So before initiating VECMO, one have to do an echo to see is there any severe aortic regurgitation, or if they are able to rule out aortic dissection also, it's fine. If there is a severe aortic regurgitation, then initiation VECMO is not a good idea without fixing the valve. Vascular access is by arterial and venous cannula. Mostly for the adult, we use 19 and 21 French. For venous, it's around 23 or 25 French. So arterial cannula are short. Only the holes will be there in the tip, and venous cannula are longer because through the femoral vein, the tip should reach close to the RA, and it has got multiple holes for better drainage. Cannulation techniques can be percutaneous, semi-Seldinger, or open method. Vascular access can be through the femoral artery, carotid artery, or axillary artery, or central ECMO through the aorta. Venous access through femoral vein, internal jugular vein, or right atrium. Cannula size we usually choose using this tabular column. So normally for children who weighs around say 10 or 15 French venous and arterial 15 French we use. For adults, we tend to put 21 size arterial and 23 size venous, which will drain about say 4.5 liters, which is good enough for a good number of patients. This is a peripheral ECMO, femoral, where femoral vein and femoral artery were cannulated with distal perfusion cannula. So when we introduce the arterial cannula, the diameter of the cannula almost fills the femoral artery. So the blood flow down to the lower limb can be affected. So we have to introduce a distal perfusion cannula connected to the arterial limb so that the blood flow through this, and then perfuse the lower limb so that the distal limb ischemia can be avoided. This is one of our venous arterial ECMO patients, poisoning, bridge to recovery. So he took, he's an MBBS college student. He took around atenolol and amlodipine, around 40 tablets of each on industrial dose of supports with low urine output. Once we initiated, within 2 hours, urine started coming, and we were able to wean off within 3 days' time. and he came to our OP. This is in 2014. In 2012, he joined our critical care unit. While I'm initiating ECMO, he was assisting to initiate another patient for ECMO. This is one of our neonate, 4 days old, with meconium aspiration. So we initiated the ECMO through the neck. So interjugular vein has been cannulated and blood has been sucked through and then given back through the arterial line, the carotid artery. Both are done in the open technique. And we maintained that patient for that baby for 11 days, after which the baby recovered and went home. There's a central ECMO in the ICU where the patient arrested with a DCM. So we immediately opened the chest and initiated the ECMO because of high inotropic support. We couldn't initiate the ECMO peripherally. The artery was in spasm, so we are forced to open the chest and introduce the cannula. Initiated, but later the parents were against the transplantation, so they signed the DNA DNR, so we couldn't help them. This is one of our patient who was referred to us for transplantation, but found to have a viable myocardium. So we thought CABG will help. His ejection fraction only 20% before the surgery, so we are not able to do it off pump. So we placed the ECMO, femoral vein cannulation, and also direct aortic cannulation. Finished the bypass graft, and then it was brought out through the chest and supported for 3 days. The heart showed a good recovery. After that, we decannulated and discharged the patient. This is one of our patient who was awaiting heart transplantation, had a previous CABG. So we introduced the peripheral ECMO through the femoral vein, femoral artery and atherosclerotic. So we couldn't approach that. Axillary artery was not atherosclerotic, so we sutured a graft in the axillary artery and then connected the cannula, and this is how he was maintained. He was having CRRT due to kidney dysfunction, which recovered within 3 days' time. Within 7 days, he got a heart, and we got his heart transplanted. This is one of our patient who was a VA ECMO, central ECMO. Both aortic cannula and RA cannula was placed centrally. Because of PGD post transplantation. Apparently, PGD has got relatively a good prognosis following heart transplantation. So coming to the management of VA ECMO, usually a flow for neonates is around 100 ml per kg per minute. For children, it's around 80 ml per kg per minute. For adults, 60 ml per kg per minute. So usually we target a map of around 60 mm Hg, not more than 90 mm Hg. What I'm talking is for adults, because more than 90 mm Hg, the chance of brain bleed is very high. And also we monitor the pulse pressure. If it is going to be more than 10, we don't bother. If it is going to be less than 10, then one have to see whether is there any LV distension, and we have to consider some form of inotropic support to have some contractility so that the LV distension will not happen. In spite of that, if LV distension is going to happen, then we need to consider LV bend, especially when we are waiting for the heart to recover. If there is a distended LV, then blood flow to the LV will be affected, and chance of recovery will be very less. And also, always we monitor saturation and also take ABG from the right upper limb, because the first branch that takes off from the aorta is the coronary artery, which we can't measure the saturation very easily. The next artery is the innominate artery, where through the right subclavian artery gives the blood to the right upper limb. So if this right upper limb saturation is good, then we can rest assured that the whole brain will get a good oxygenated blood. So this Harlequin syndrome, one have to know when initiating the VA ECMO. And usually this happens only in VA ECMO. And also if the lung is dysfunctional, so lung is not functioning properly, only this can happen. So when we are going to place a VA ECMO, for example, it's around patient's cardiac output is around 5 liters, and 3.5 liters is the flow here. Remaining 1.5 liters will go through here. But after the going to the bad lung, the impure blood will come to the LA to LV, and then will be ejected out. First branch, as I said, it's a coronary artery, and the whole heart is going to receive a deoxygenated blood, and recovery can be hampered. First, to try the medical means of improving the lung function, like adjusting the ventilator, increasing the PEEP tidal volume, and also having some nebulizers, and also diuretics to improve the lung function. If those things are not possible, then consider placing another cannula, as Dr. Sunil Pamodi said, in the IJV to convert into a VAV ECMO, and then give the blood through the IJV so that the pure blood also will reach the coronaries and recovery of the heart can be speeded up. This is one of our patient who had a lung failure awaiting transplantation, had a cardiac arrest. We placed veno arterial ECMO through the femoral arterial vein and then went on, but the heart didn't recover. We suspected harlequin and then placed another cannula in the neck, and then immediately the heart picked up. Prevention of LV distension also is very important for the LV recovery, as I already told. LV distension usually clinically we can see by rising peak airway pressure on the ventilator, and also pink frothy sputum we can see in the ET tube because of raised LAP and pulmonary edema. So first we have to manage by medical management. Then depending on the amount of LV dysfunction, we can try intra-aortic balloon pump. And also like if those things are not helping, then come to LV venting. So LV venting can be done by various methods. One of the form is impeller device, that is called as ECPella, where veno arterial ECMO has been placed through femoral artery and femoral vein. There is a LV distension, so impeller is also placed to decompress the LV. So LV can also be decompressed through the, say, cannula in the LA through the RA. This is through the IVC, through femoral vein, IVC, RA, puncture the septum, go to the LA, and then suck the blood. So this needs expertise to place the cannula. And also often when the suction force is high, there is a atrial suction event happens. And also once it is removed, there is a large atrial septal defect. So because of these things, it is not routinely practiced here. What we practice in our center is LV vent. Just open the chest. This is a small incision. Because of a distant LV, it will be projecting here. Just take a purse string and place the cannula here. This is going into the LV and then drains it. This is connected to the venous limb so that the blood is sucked and the LV is LV distension is prevented. So coming to the management part, so measure the pre and post membrane pressures. So the membrane pressure, like the line pressure after the pump, should be less than 300 millimeter Hg. Otherwise, blowout chances are high. And also, difference in the pressure gives us an idea. Post membrane pressure is always higher than the pre membrane pressure, and the delta P usually it should be less than 30, and more than 50 we consider clot in the oxygenator. The rising trend gives a clue that we need to change the oxygenator. Also, there are various parameters like we need to monitor the pre and post membrane gas every day. And if it drops, say, less than 250, that is the time we need to consider oxygenator chain. Drop in the post membrane gas along with rising delta P indicates that we need to change the oxygenator. And pre-pump pressure gives an idea about how much volume the patient has. And if it is going to be less than 70, then we need to give some volume to prevent shattering. So we usually use antibiotic prophylactically for 48 hours. After that, we stop it. Then if any signs of infection, we tend to identify it and according to the culture, we manage. And we start the feeding early. And also we stop the sedation as quickly as possible and make the patient awake and participate in the physiotherapy. Is one of our patient we on VA ECMO, and he has been extubated and communicating well. And is the patient who is doing physiotherapy. We also give limb physiotherapy also with letter device. And labs, usually ACT we maintain between 180 to 200, APDT of around say 60 to 80. If there is a bleeding, we tend to run a lower ACT of around 150 to 170. Hemoglobin of around 9 to 10 grams. Platelet count 75,000. If there is a bleeding, then we raise the platelet to around 1 lakh. If there are bleeding, we need to check the iron and fibrinogen also to have an idea about what is happening there. Low fibrinogen may be an indication of some clot formation or subclinical DIC because of the oxygenator. hemolysis. If the bilirubin is rising, then it's worth checking the plasma-free hemoglobin, LDH, and reticulocyte. Usually, the trend gives us an idea whether the significant hemolysis is going or not. This investigation to be done along with other ICU routine tests. Coming to the complications of ECMO, bleeding incidence is reported and it varies from center to center. It's around 5 to 79%. Ours is around 12%. And infection around 17 to 49%. Ours is around 23%. Limb ischemia is around 13 to 25%. Ours is around 9%. Neurological evidence around 10 to 33%. Ours is around 15%. So one of a patient who had a intracranial bleed following VA ECMO, and this is one of the life-threatening complication. So any other bleed we can manage to some extent, but the brain bleed and significant GA bleed will be in trouble. So also next important thing, especially in our country, is the infection. So for that, we need to take care of the hand hygiene, environment hygiene, and also handling the lines should be proper and have to be supervised by us. And once the patient has adequate tissue perfusion with low or no catecholamines or any supports, satisfactory function of the other organs, then one should think of weaning. So weaning the ECMO should take place at 0.5 ml per minute every 6 hours. With that, each 6 hours, we have to test there is adequate tissue perfusion with in terms of ABG, lactate, and good urine output. And also, we can do an echo to see how the cardiac function is. And we can wean gradually to 1 liter per minute. Then the heparin to be continued in the weaning phase. And lower the flow, higher the ACT we need to keep up. We'll keep the ACT to higher level to around 200 to 220. And once the weaning is around 1 liter, we generally take it to the theater and reduce to around 500 ml, leave it for 2 hours. If it is okay, we'll remove it. The small support, inotropic support. But sometimes centers, what they do is, as Dr. Sunil Pogoni pointed out, they place a bridging site here, and they usually clamp these two, and the ECMO will be supported with this. And these two will be clamped, observe for 6 hours to 8 hours, and they decannulate. But in between, you need to release the clamp to flush the blood. Otherwise, a clot formation can happen. So before decannulation, make sure the coagulation parameters are all right. Hemoglobin is around 9 to 10. Platelet is reasonable, around 75,000 or more than that. EAB is also good. Usually, we stop the heparin 30 to 60 minutes before decannulation, and we keep the ACT around 130 to 150. After decannulation, we may consider protamine. And venous side, usually we remove it and then do a compression and then skin, additional suturing in the skin. But arterial, we always do surgical repair. So if the patient recovers, weaning, decannulation, everyone is happy. If the patient is not going to recover, what we are going to do? That is also important thing we need to touch upon. So poor recovery period is predicted when the VA ECMO is around, say, second week. If the heart is not going to recover, very unlikely it is going to recover. But if it shows some sign of recovery, we can wait up to 4 weeks' time. But after 4 weeks' time, the chance of recovery of the heart is almost nil. So then one have to consider transplantation or LVAD. If those things are not there, then we have to counsel the family towards DNA and DNR. So this is the ELSO registry in June 2023, this month. So the results of VA ECMO is poorer than VV ECMO. So ELSO wise, the VV ECMO results is around, say, for neonatal is around VA ECMO. The neonatal is around 44%, pediatrics around 55%, adult is around 46%. Ours is also almost the same. For pediatric, our result is around 50%, and cardiac, our results around, say, 40%. In summary, ECMO is only a temporary support. We should have some plan for exit. So it should be considered for reversible cardiac failure and circulatory shock, or else as a bridge to transplantation or VAD. Harlequin syndrome or LV venting should be considered for all VA ECMO in appropriate cases. Main complication in any other ECMO is bleeding and infection. Thank you very much. I can take questions.
Thanks a lot for that wonderful talk, sir. Actually, this ECMO session is going to inspire more of people who is going to run ECMO in future, I guess, sir. Thanks for your time and knowledge, sir. Actually, I don't see any questions here, sir. Just out of interest, what are the most common indications you face in your center, sir, other than transplantation?
We say myocardial infarction, acute myocardial infarction.
Okay, sir. So of late, that is one of the upcoming indications. So how would the outcome in this myocardial infarction, sir?
It is quite good. Like it's all the time of referral. Previously, it was quite bad because the time of referral, they try everything and then refer to us late. But we had a meeting and then we formulated that. So now we initiated on time. And the results is around close to 50%. The 40% result, why we have is because of the previous one. I think since 2016 or 17, the results are pretty good, I have to say.
Yes, sir.
In poisoning case, it is almost 100%, the results are.
Yes, yes, sir, definitely, sir. So in acute coronary syndromes, how early do you initiate, sir? When do you initiate actually, sir?
So as I told you before, like we have to see the tissue perfusion. If the hemodynamic deteriorates and your lactate and other things, lactate and all, we have a cutoff point around 5. Once
Yes,
it
sir.
reaches 5, the call will come to us. Then we'll go on to assess. And then if needed, we start all the inotropes, whatever we can, we need to support and see and wait for 2 or 3 hours. If that is going to show a declining trend, like lactate from 5 to increase to 7, then we have to counsel, we'll be counseling the family and initiating it. If it is going to be 5 to 3, then we tend to wait.
Okay, sir, fine. Thanks a lot for your time and sharing the knowledge, sir. Sorry, sir, we have one question here. How much ECMO help in COVID? What is your outcome, sir? From Dr. Muthukumar.
COVID, actually, like we have a result of close to around 70%. It doesn't mean that we are very superior to all the results all over the world. We are very choosy in choosing the patients because we had only 15 ECMOs. At a given point of time, we can run only 15 ECMOs like that was there. So there are around, we'll be having a waiting list around 40 patients. So really deserving patients, like young patients with no comorbidities, we chosen and then initiate the ECMO. And then we had showed a 70% result on that. And in all patients, we tend to extubate them fast and then mobilize them and make them to stand up and do all the things. So it actually helped us and with the 70% result.
Okay, sir. So thanks a lot for your time once again, sir. Thanks for joining us. Thank you, sir.
Most welcome. See you.
Thank you, sir. So moving on to next talk, I invite Dr. Pranay Oza, sir, on VV ECMO. So a few words about him. He is ECMO co-director, Riddhi Vinayak Multi-Specialty Hospital in Mumbai. And he is EAEC certified. And he is the current president of ECMO Society of India and secretary of SWAC also. And he has numerous publications. And area of interest is more of ECMO and critical care. Over to you, Pranay, sir, on VV ECMO. So now you can share the screen, sir.
Yeah, I'm just sharing my screen.
Yes, sir. Your screen is visible, sir. You're audible, sir.
Okay, fine. So good evening to all. First of all, thanks to organizer for giving me an opportunity to speak. I have no conflict of interest. This is the Riddhi Vinayak Hospital and our ECMO unit and simulation station. So what I'm going to talk is about VV ECMO today, indications and then the management of VV ECMO. So indications of VV ECMO is in respiratory critical care. It can be as a bridge to recovery for an acute respiratory failure or post-transplant. It can be bridge to transplant or waiting for the pre and post or during transplant to the patient. And it can be for the donor also before you retrieve the patient for a brain dead donor, before you can retrieve the organs. If the patient is unstable, you can put the patient on ECMO or for organ preservations. And it can be used for some procedural supports, like when there's a surgery of airway or when you want to do a whole lung lavage and patient is not maintaining on even one lung ventilation. In that case, you might have to think in terms of putting the patient on ECMO for a short time, do a lung lavage and come out. So these are different indications for bridge to recoveries, ARDS, pneumonia. Important is in ARDS, you can use for tropical illness as well as H1N1 and COVID. And what we have found in that tropical illness ARDS, usually they respond well and they respond within 8 to 10 days. H1N1 ARDS usually takes 2 to 3 weeks time, and COVID usually takes 4 to 6 or more than that 6 weeks time to recover. Other indications remain like pneumonia, status systematicus, inhalation pneumonitis, near drowning, or diffuse valvular hemorrhage, polytrauma, poisoning, autoimmune lung disorder. So anything which causes the respiratory failure and which can be recoverable, it becomes an indication for an ECMO. The exclusion criteria remains the absolute indication is only when you don't anticipate any recovery of the organs. Without any, you don't have any plan for a transplant, you don't have a plan for assist device, and you don't have any chance that the organ will recover, that becomes an absolute indication and contraindications. Relative contraindications can be some disease which is irreversible disease, or the age criteria, or the patient is on ventilator for more than 7 to 10 days with a high ventilator setting, that is P2 pressure is more than 30 and FI2 more than 80 for almost 7 to 10 days, then you can consider as a relative contraindication, because if these patients are willing to go for a long ECMO or they are willing to go for even transplant, then in that case, it is not a contraindication. Any bleeding, central nervous system bleeding or any bleeding which is non-compressible becomes an relative contraindication. You don't know the neurological status and immunosuppressants, there remains relative contraindications. But most important is low platelet counts or pulmonary hemorrhages or moderate inotropic supports is not an contraindication for VV ECMO. So that is most important. It's not that patient is on moderate inotropic support, so you will require patient to go on VV ECMO, or leptospirosis patient with a platelet count less than 50,000, pulmonary hemorrhages. Again, they don't become contraindication for ECMO. Rather, the ECMO has got very good role and good outcome there. In a chronic patients, when there is an acute or chronic respiratory failure or patient is waiting for a lung transplant, it can be used as a bridge to lung transplant. As I told you, it can be used for airway surgeries. If you have some airway surgeries, you can use ECMO to help during the surgery and even post-surgery, give rest to the airways. You can put the patient on ECMO and keep the patient on ECMO for a few days. Okay. ECMO in lung transplant, it can be used for, as I told you, for the donor. Before the patient is before retrial, the patient becomes unstable, and you might require to give the support for organ retrieval, or in case of brain dead donor or a heart-beating brain dead donor or non-heart-beating donors, you can use both ECMO for stabilization of the donor, and then it can be used for the even recipient also. Recipient is a pre-transplant, or can be used during transplant or even post-transplant. Remember, the post-transplant, the indication of ECMO becomes when the PF ratio is less than 200. Usually we go by the PF ratio is less than 100, but here in the post-transplant case, it is always, because it was supposed to be a normal lung. So if the PF ratio goes less than 200, you have to consider the patient for the lung support. You have a CO2 removal device that also can be a VV-CO2R. So it can be because of acute exacerbation of COPD or asthmatic patients, or in case of early ARDS or acute lung injuries where the CO2 is a major concern rather than the PO2. In that case, you can always consider CO2 removal device. It can be even used as a step down from ECMO. So when the patient usually recovers after a long ECMO, they usually have a CO2 which is high and not the PO2, and the PO2 improves. So in that case, you have to just take care of CO2. So you can might convert from ECMO into an ECCO2 removal. And this is what even the Madan has shown in the graph of ELSO statistics, where if you see the statistically, there are more cases of pulmonary cases or respiratory cases in pediatrics, adults, and neonates, all cases, while the cardiac ECMOs are less as compared to your pediatric. And the even the outcome is usually good, around 60% in a VV ECMO and around 45 to 50% in VA ECMO. And if you see, if you see the adult respiratory ECMOs have been picked up usually in last 5 years. That is almost 28,000 cases. If you see here, while the pediatric and neonatal respiratory cases are much less as compared to the adult respiratory ECMOs. Now, when should you consider ECMO, respiratory ECMO, VV ECMO? When the risk of mortality is more than 50, is going to be more than 50%. So whenever you have a patient who has got a PF ratio of less than 150, you start thinking about ECMO at that particular time. You speak to the family, because it takes logistically some time for the family to decide to go ahead, and you take some time for you to take care of arranging everything for the ECMO. So it's always consider ECMO earlier, If the person improves after that, then you don't have to go for ECMO. But if the patient still worsens, then in that case, you have to, you can go for you can start with ECMO immediately. So with the consider ECMO is indicated when the risk of mortality is more than 80%, when the PFS ratio is less than 80 to 100, with a FIT of more than 90%, Murray score of more than 3, or there is a severe ailing syndrome or oxygen index of more than 30. But most important is bridge to nowhere is not a good idea. So you have to always think of ECMO only when there's a chance of either recovery or you have some destination. Then only you should think of ECMO. Now the management of ECMO depends upon what the purpose of VV ECMO is. Whether you started VV ECMO as a rescue therapy, whether you started use ECMO as a lung rest, whether you are going for a bridge to transplant or whether you are going to go for transient procedure support. The management differs in that case. If it is a rescue therapy, definitely you have to put the person on ECMO and there is a life-threatening hypoxemia. You have to go for a high flow ECMO and you have to continue the ventilator. For the lung rest, if the patient is early in the time of initiation of ECMO, you can always think of getting the ventilator settings down immediately or early and try to get the patient extubated and do an awake ECMO. Bridge to transplant is usually, most of the time, you usually plan for a double lumen cannula and do a awake ECMO. That is usual planning. And transient procedure is just going to be for few hours. So you can even use your regular oxygenator also if it's going to be only for 4 to 6 hours procedure. So what is the cannulation configuration? Usually it can be bifemoral. So you can cannulate both the femoral vein, for a drainage and return, or it can be femorojugular, or it can be double lumen cannula. So this is the various configuration you can see. This is going to be femorojugular. So you are draining from the femoral vein and returning to the jugular. This is femoral. So we are draining from the femoral vein. You have to see the distance between these. The return cannula is going to be in RA. Another femoral cannula is going to, the drainage cannula is going to be somewhere in the below the hepatic IVC. So that is you need to. And this is if you require to put an additional cannula, then it is going to be VVV. So you have to drain from the one femoral vein, return drain from another jugular vein, and return is going to be in the RA. So that is VVV cannulation. I am going to discuss this later. And then you have double lumen cannula. If you have double lumen cannula, you might just have to put a single right jugular vein cannulate and put the double lumen cannula. You have one drainage port in the SVC, another drainage port in the IVC, and you have return port in the RA, which is facing towards the tricuspid wall. So what's the goal of VV ECMO? You want to basically you want to keep the patient alive till the time the patient improves, and you want the lungs to open up fast so the recovery can be faster. So what is the goal is to give adequate and safe support. These are the two words which are very important. You have to give adequate support and a safe support. When I say adequate, it means even the saturation of 85 is adequate. So you don't have to go for saturation of 100%. So give adequate support. If your lactates and everything are fine, even 85 saturation is good enough. So give adequate and safe support. And try to speed up the recovery of the lungs. Now, how will you try to speed up the recovery? By giving rest to the lungs, preventing the ventilator-associated injuries, and give adjuvant therapies, physiotherapy, proning position, everything, thereby try to help the lungs to recover fast. So when you initiate ECMO, what are the parameters you are going to set? Okay, you usually go on ECMO for a VV ECMO, you go usually slowly on full flow, around in 20 to 30 minutes. Basically, start with 20 cc per kg per minute as an initiation, and then every 5-10 minutes you can keep on increasing the flow by 5 cc per kg per minute. Okay, so you can keep on increasing those every 5 minutes or every 10 minutes. Your target flow is usually 120 to 150 cc per kg per minute, but it depends basically on whether you achieve the targets. Okay. So to increase the flow as per your targets, so your targets saturation is 90%, 85%, 95%. So depending on target, keep on increasing the flow. Once you achieve the targets, come down on the ventilator settings and go to the rest ventilator settings. And you can adjust the sweep gas initially as 0.5:1, and then you can go up, increase the sweep gas up to 1.5:1 with the blood flow. Always remember, sweep gas, you have to go very gradually up. You have to keep the sweep gas low, because if you increase the sweep gas, the CO2 clearance will be faster. And most of the patients with ARDS, they have high CO2. So if you rapidly correct the CO2, it can give us some neurological injury. So you have to be very mindful about sweep gas. Now, what are the targets for the VV ECMO? Basically, the adequacy and efficacy of VV ECMO is judged by the arterial saturation, and the saturation can be anywhere between 80 to 95% is good. How will you judge the safety of the VV ECMO is by seeing the minimum resistance reduction and to see the adequacy of the flow. So basically, if you want to change anything in the CO2, you have to change the sweep gas. Whenever you want to change anything in the PO2, if you want to increase the PO2, you have to increase the blood flow. And if that is not helping, there's anything problem in the tissue perfusions, you have to get the metabolic rate down by cooling the temperature. So now when patient is on ECMO, you have to always remember that the patient has got two circulation that is existing. One is the native and second is an ECMO circulation. And you have to monitor both the circulations as well as you have to manage both the circulations. That is what is most important when the patient is on ECMO. So you have to monitor all the patient, all the parameters which is of ECMO as well as the patient. So patient parameters usually monitored by clinical and laboratory, and the ECMO parameters usually monitored by the circuit monitoring. So circuit monitoring includes the circuit pressures, the P1, P2, and P3 pressures. P1 pressure is usually the pressure which the blood is being taken out from the pump, taken out from the body, and that is usually a negative pressure before the pump. Okay, and P2 and P3 pressures are P2 is before the oxygen and P3 is after oxygen. That tells you about the transmembrane pressures. So that tells you about the functionality of the oxygen. Then you have to check the RPM in the blood flow, how much is flow RPM and how much is the blood flow, because this is centered with the pump. So this with the same RPM, the flow can vary with the preload and change in the preload and change in the afterload. So you should always keep in mind the RPM flow ratio, and you have to check the circuit from head, like what we take it from head to toe. You have to check the circuit from vein to the return drainage, from drainage port to the return port. You have to check the circuit entirely for clots, disconnection, loose connections, kink, etc. Clinical monitoring is always vital parameters that are very important that we need to see. The cerebral saturation, if possible, that is again a good sign, or otherwise at least neurological assessment every day by giving a sedation break. The vascular status, the neurological status, and the urine color and output both are important. This is laboratory monitoring. We usually do it before the ECMO. What are the investigations you need to do? Immediately post ECMO, you need to just do CBC, ABG, ACT, X-ray chest, echo if it's VA ECMO. Then first week of ECMO probably might require little more investigations, but then after once the ECMO remains for a long time, your requirement of investigations keeps on decreasing. So it's not that every 4 only you have to do ABG or every 2 only you have to do ABG. You go more by clinical criteria rather than going by the laboratory investigations. So the management of VV ECMO, as I told you, the way you do management of ECMO, monitoring the ECMO circuit as well as patient. Here, the management of VV ECMO, management of ECMO per se, the management of the lungs, and the general management of the other organ functions. So you have to manage all three. How will you manage ECMO? By adequate and safe support. So you have to maintain the blood gas, you have to maintain the anticoagulation, and avoid complications in terms of recirculation infection. Management of lung includes give rest to the lungs, avoid further damage, and to help the lungs to recover fast. You have to do ventilative management and help the lungs to recover fast. So do all adjuvant therapies. And general management is by giving a general nursing care and taking care of rest of the organs. So anticoagulants, basically ACT usually target to 160 to 180 for a VV ECMO. And suppose we need to go for a VVA ECMO, then probably we have to increase the target to 180 to 200. Usually we use heparin as a common, but the risk of heparin can increase the risk of bleeding. Nowadays, the trend is coming of using a bivalvulotin, but again, bivalvulotin is more towards the thrombotic side. So when there is a slow flow, bivalvulotin can increase the risk of thrombus formation. So you have to be little careful about it. But then trend is going more towards the bivalvulotin side. ACT and APTT both you can monitor. Again, trend is going more towards nowadays with the APTT. Whenever there's a bleeding, you have to go for an advanced monitoring either in terms of TAG or ROTEM and take a call of transfusion based on the TAG and ROTEM reports. What is the ventilator strategy? Ventilator strategy is you want lung rest and recovery is going to be your priority. So you have to just wait and watch, give ultra protective ventilation strategy, recruitment of the lungs only when the lungs is going to, once lung starts opening or once lung starts recovering. There's no point in recruiting the lung when the lung is diseased completely. So give a lung chance to heal and open gently. That is most important. Usually we go for a ventilator strategy as a rest ventilator settings. Gradually we go on rest ventilator settings. Respiratory rate we keep around 10. Peak pressures we always try to restrict less than 25. Peak of around 10 to 12. I ratio is 1:1, 1.5 to 1:2, and FI2 can keep anywhere between 21 to 40%. This is what usually we practice when we initiate VV ECMO. First 48 hours, we usually go get the PEEP down gradually. We go to the rest ventilator settings, prone the patient if there's if it is required, and if there's any evidence of barotrauma, then we get the peak pressures down to 20 and keep PEEP 0, and then titrate the PEEP depending on how much the bubbling is. After initiation of ECMO for a few days to weeks, when the patient is stabilized, we try to reduce the sedation, try to keep the patient awake. We go for a spontaneous mode of ventilations, either PSP, PRV, or bilevel mode. We accept the RR respiratory rate up to 30. If it is going more, then we increase the sweep gas and try to get the CO2 down less than 30. Most of the time it helps and patient tolerates. If the patient tolerates well, then we extubate the patient. If the patient does not tolerate, we go back on the control mode of ventilation, and then we can try to evaluate why it didn't tolerate it and treat it. This is a blood gas management. The adequate, as I told you, is 50, PO2 of 50, SPO2 of 85, more than 85. But what even we accept is even the PO2 is 40 to 45 and saturation 70 to 75. If that is a condition, then we observe the sensorium, we observe the hemodynamics, we look at the urine output, and we look at the lactates. If all this is fine, patient is good, sensorium is good, hemodynamics are stable, urine output is adequate, lactates are normal, then in that case, we don't usually treat, we just accept this. If it is not maintaining, then probably we need to treat it. So we need to improve the oxygenation and we need to decrease the PCO2. So how will you increase the oxygenation? We'll come to the next slides. PCO2, you always increase the sweep gas and get the CO2 down. But always remember that your Y is not maintaining, you have to find out the cause and treat the cause. That is most important. Okay. So the child is like this, conscious alerts, even the saturation 70, you accept it. So what are the factors which affects the SpO2 on VV ECMO? That is, one is ECMO circulation. So ECMO flow, ECMO FiO2, oximeter status, and recirculation. All that affects the saturation on VV ECMO. NATO circulation, that is the ventilator settings, the lung status, again that determines the saturation if the ventilator is if the lung is contributing something. And most important is the fraction of cardiac output oxygenated. That is important. The ratio of ECMO flow and cardiac output. See, whenever the metabolic activity increases, the cardiac output increases, but the ECMO flow remains same. So because of dilutional effect, what will happen is the saturation will drop. And you usually see when the patient wakes up or whenever anything which increases the metabolic activity will decrease the saturation in VV ECMO because of dilution. So how will you manage oxygenation? First is correction of the causative factors. If the recirculation is a causative factor, control the recirculation or try to minimize the recirculation. There is always some amount of recirculation is going to be there when the patient is on VV ECMO. You have to just minimize it and keep it less than 30%. Second most important is try to improve the organ recovery. That helps you to get the ECMO out fast. Decreasing the demand. So you can manipulate the cardiac output, as I told you. Whenever the cardiac output increases, so you are going to get to this situation. So try to decrease the cardiac output by controlling the fever, sedation, and whatever the cause which has caused increase in cardiac output, try to control that and get this cardiac output down. Or if nothing is helping, you can consider getting doing hypothermia. And the most important is increase the supply. So you can increase the blood flow of the ECMO. That can increase. If the ECMO FiO2 is kept low, you can keep the ECMO at 100%. And if that is not happening, you can think of increasing the hematocrit so that the oxygen delivery improves. So corrective the corrective factors is the mechanical issues and technical issues. You have to see if there's oxygen failure, try to correct the oxygen, to change the oxygen. If there's a recirculation, As I told you, minimize the recirculation. Improving the current factor function is most important, and correcting the demand and supply ratio, that is. So how will you improve the parenchymal lungs function? If you see lungs are a lot of secretions and lungs are absolutely white, can do bronchoscopy and do tracheal lavage and get the secretions of blood clots out. You can, if there's a pneumothorax, treat pneumothorax. Most of the time when you initiate ECMO, we give a lot of fluids, so you have to give diuresis so that the lungs becomes dry, and probably that improves the lung functions. Lung recruitment, if the lung starts opening up, then at that stage you can start think of lung recruitment and giving a prone position. All that is going to help the patient to improve the lung functions. Okay. So prone position is not basically to just to improve the oxygenation, it is basically to give the dependent part of the lungs to open up, and that's why it can improve the oxygenation. It is always feasible, but you have to take care that cannula kinking should not be there, decannulation, disconnection should not occur, the flow and RPM ratio should maintain, there should not be recirculation, and keep a watch on saturation. So usually we try to put prone all the patients if they are within the 6 to 8 hours of initiation of ECMO. If this tidal is less than 2 ml per kg in a rest ventilator setting and X-ray is completely wiped out, hemodynamically stable, then usually we prefer to give proning cycle for 16 to 18 hours for 3 to 5 cycles. If the patient is doing well and if he is maintaining good saturation, even with the and the tidal is more than 3 to 4 ml per kg, then in that case we may not go for a proning and might think of doing an awake ECMO and try to get the patient off ventilator. Next important thing is the chest physiotherapy. So you can give all possible chest physiotherapy. You can give postural drainage, percussion, tapping, vibration, steam, nebulization. If the patient is extubated, all physiotherapy should be tried, and therapeutic bronchoscopy is required. Active and passive limb physiotherapy. Try to mobilize the patient. Try the patients to be with the family so that all that things can help the patient to recover fast. Okay. This is the bronchoscopy, and then what are the big blood clots we have removed during the ECMO run. Another way of improving the oxygenation is manipulation of cardiac output. Treat the cause of increased cardiac output. So whether it is a high fever, sepsis, patient is awake, restless, to try to treat that. Get the output down by use of beta blockers or hypothermia and increase the blood flow. That is the way you can manipulate the cardiac output. As I told you, if the cardiac output usually improves, then that will improve the tissue perfusion and that improves the oxygenation. But at the same time, if the cardiac output increases, it decreases the, it causes more of a dilutional effect, and because of that, and because the lungs are not contributing much, okay, that dilutional effect, the ECMO flow is less as compared to your cardiac output, and that's why the saturation usually drops. If you induce an hypothermia with a temperature from 37 to 34 degrees, the heart rate comes down, your cardiac output will decrease, and with the same flow, the fraction of cardiac ECMO flow with cardiac output increases. So here you have 75% of the blood flow is ECMO flow, and there's why the saturation will increase from 80 to 94. So, but just by decreasing the metabolic activity or by just decreasing the temperature, you can increase the saturation without any change in the ECMO flow. But then definitely why you don't cool the patient? Because it will increase the risk of infection, arrhythmias, coagulopathy, and drug metabolism gets altered. And that's the reason we don't try to cool all the patients. And that we keep it as a last options, later down on the options. Another way we can increase the oxygen delivery is by increasing the hematocrit. So if the flow is already on 5 liters or already 6 liters of flow, and in spite of that patient not maintaining saturation and your lactates are going up, in that case you need to treat it. Then in that case, try to increase the hematocrit to 40, try to maintain hemoglobin more than 10, and so that they can increase the oxygen delivery to the tissue. And maximize the blood flow. That's the most common way which we increase the ECMO blood flow. But when you increase the ECMO blood flow, you have to always weigh the risk versus benefit, because if you go for more than 6 liters of flow, the risk of hemolysis increases. So, and the blood flow issues. So you have to always maintain what will be the most balanced. Okay, if you don't get enough flow, then you have to put one additional cannula to get the flow. And always remember, when you are increasing the flow, you have to see the capacity of your oxygenator. Most of oxygenator in adult oxygenator has got capacity of 7 liters. Some oxygenator has got capacity only 5 liters. So if you are going up of the flow, then the rated flow of oxygenator, then you need to put an additional oxygenator and you have to manage dual oxygenator. If anything, nothing is helping, the probably the last resource is going to be converted from VV ECMO to VVA ECMO. And that is required if the patient goes into cardiac arrest during the patient on VV ECMO run and not responding to your regular cardiac massage, or patient has got a right side heart failure, or there's a lot of recirculation that is still not improving the hypoxia. Now, other than the regular your UV ECMO management, the common management is going to be fluid management. Usually, we try to restrict the fluid in the most of the cases. But again, first 24 to 48 hours, because patient goes into surge reaction, they might require a lot of fluid because of the capillary leak, high flow of ECMO, bleeding or diuresis. You might require a lot of fluid. The fluid assessment can be done by CVP, can be done by pre-pump pressure. That is most important. Usually, we go by pre-pump pressures rather than the CVP. Okay, and usually you have to give maintenance fluid. Hemodynamic management, we try to maintain the mean artery pressure of 70 in adults and around 40 to 60 in pediatrics to neonates, depending on the age. Inotropic support in most of the cases, still almost around 60% of cases do require inotropic support for some time. But then gradually, once the patient start improving, the inotropic support comes down. The reason for inotropic support is basically patient might be in a surge reaction of sepsis, and that's why they might require inotropic supports for some time. Many of the times, once you put the patient on ECMO, even they are on inotropic support before putting the patient on ECMO, they are on moderate inotropic supports. But once you put the patient on ECMO, the hemodynamics improves faster, and many of the time they goes into hypertensive response. The commonest cause for hypertensive response is the sedation, which becomes less because most of the sedation get absorbed to the circuits. So what will happen is your sedation, whatever you are giving, that is inadequate sedation, and that leads to you have to go give sedation to them. If that is not helping, you can use antihypertensive in terms of either NTG or lobetalol or esmolol. If the heart rate is more, then probably we prefer lobetalol or esmolol. That helps us to get the heart rate also down, get the cardiac output down, and thereby it can improve the saturation also. Antibiotics, as I said, prophylactic antibiotics are usually there when the patient is we put on patient on VV ECMO. So we continue almost the same antibiotics. The incidence of secondary sepsis is almost 20%. So we usually prefer the higher antibiotics should be spared. So if the patient is indication is viral pneumonia or viral ARDS, usually don't prefer to continue them on antibiotics. As Dr. Madan said, you can just give 3 doses of antibiotics for a procedure coverage, and then you can stop antibiotics if there are no absolute indications to continue antibiotics. But keep a low threshold. Whenever you feel there is suspicion of a infection, you can restart the antibiotics. Blood products administration usually we require because when we put the patient on ECMO, almost in adult patient around 700 to 800 ml of there's a fluid in the circuit. The circuit volume is around 700 to 800 ml. So when you initiate ECMO, that 700 to 800 ml of blood comes out in a minute. So you are losing almost 2 units of blood, and the same amount of fluid goes in the circuit in the patient. So it was hemodilution. So if you are not priming the circuit with the blood, then probably you can cause hemodilution as well as the blood loss is there. So hemoglobin, which was initially say around 9, can drop down to around 6 or 7. So you have to be always mindful about that. There's a lot of consumptions during that, and even there's a bleeding is there, so you might require a lot of blood product transfusions. And this is what the threshold for blood transfusion. We keep maintain hemoglobin around 8 to 9. If it is less, then we usually transfuse the blood. Platelet usually we maintain in VV ECMO, even except up to 30,000 if there's no bleeding. Obviously, if there's a bleeding, we intend to keep it more than 1 lakh. For FFP transfusions, if INR is more than 2, if there's no bleeding, we transfuse. If INR is more than, if there's a bleeding, if the INR is even more than 1.5, we give FFP. And whenever there's a HEPA resistance, we give FFP. Cryo, our target is around 100 to 150, and we infuse. If the fibrin is less than 100, and if there's no bleeding, if there's more than, if there's a bleeding, we try to maintain a fibrin more than 150. Okay, and albumin, if there's a less than 2.5, we tend to transfuse albumin. Sedations, usually remember, analgesic sedation usually required when you initiate ECMO just to decrease the oxygen consumption when the increased metabolic activity is there. Usual our intention is to keep the sedation for 4 to 5 days and then get rid of sedation if the patient permits you. Remember, most of the sedations get absorbed in the circuits. Lipid-based sedation like propofol can even alter the oxidative function, so you have to be avoid it. Patient is usually in severe catabolic stress, so you have to give nutritional supports. Enteral nutrition is possible. Try to give enteral nutrition. Give 60 to 90 kilocalories and high protein diets. Almost you can start with 1 gram and then you can increase up to 2 grams per kg per day, depending on the patient's serum protein levels. TPN only if the patient is not tolerating enteral feeds. You can give all general nursing cares, but always remember no routine change of lines and catheters that is to be there because it will increase the risk of bleeding. Most important is your checklist and documentation during the nursing care. Now, many of the time you are giving any position to the patient. Okay, what are the safety precautions you should take care is secure the cannula properly. That is most important, and hold jugular cannula. The neck cannulas are the one which can come out easily because they are only 10 centimeters to 15, say anywhere between 5 centimeter to 15 centimeter inside the jugular vein, depending on the neonates to the adult side. In adults, it's around 15 centimeter, and neonates might be only 4 or 5 centimeter. It is going to be inside, so that cannula can come out easily. So you have to always keep that thing in mind. Look for the RPM and flow relations. How is the RPM and flow relations? Look for any kinking, any disconnections, and look for a recirculation and desaturation. So whenever you are doing any positioning, giving proper position, doing X-ray, giving back care, or drawing the patient, you have to take all precautions, please. Then the management of VB ECMO complications. The commonest complications is going to be recirculation, pulmonary hemorrhage, and then the right heart failure. If there is a prolonged ECMO, you might get it. Okay. So recirculation is the whatever blood is giving, this return blood is there. That same blood gets come back to the drainage side. That is what we call as the recirculation. That is, we can see if the cannula position is not proper, you can see that. Usually, there is always some recirculation. Up to 30% of recirculation you usually accept it. How will you diagnose recirculation is by seeing the cannula position, by seeing the color of the tubing, and by the turbodilutional techniques. So you can see here, it's the VVA ECMO. You can see this is the return cannula, and this is the drainage cannula. So you can see both the colors are becoming the same. This SVC drainage cannula is not VVA ECMO, is dark color. So because the colors are same, it suggests your recirculation. You can see here in this there's no recirculation. There's a good color difference with the double lumen cannula, but here there's hardly any color difference even with the in the double lumen cannula. So again, this cannula is misplaced somewhere, and because of that there's a recirculation. So one thing you can see is color of this. Another way of calculating the recirculation is by seeing the pre-oxygenated saturation, the post-oxygen saturation, and take a venous saturation. Venous saturation usually to take the vein away from the return cannula. So usually you have to go and take the blood from the opposite femoral vein or something to calculate the recirculation. As I told you, the 30% of the recirculation is acceptable. Anything more than 30% recirculation is not good. And then in that case, you need to change the cannula position. Okay. Or you can have a ELSA monitor which can calculate the recirculation with the help of ultrasound dilutional thermal technology, so that can calculate the recirculation. Again, it's not available still in India. You can get it only. There are some companies which have started importing this monitor, but still not commonly available in India. So what are the factors which affect the recirculation? One is the pump flow, second is the catheter position, third is the cardiac output, and the right atrial size. So usually when you see, when you increase the flow, you can see this graph. Okay, your flow, when you increase the flow, the effective flow increases. Okay, and at one particular time it gets plateaued, and then the saturation start decreasing. The effective flow will decrease. But this is a recirculation curve, and the recirculation curve is usually a linear curve which will keep on increasing once you increase the flow. So always this is the point where you should know that you cannot go above this flow. Okay. So this is what we call as the defining the curve. So once your flow reaches to this level, if you go up on the flow, that will cause more of a recirculation and your saturation will further drop. So how will you come to know about this clinically? What you need to do is, whenever a patient on ECMO, suppose your saturation drops, what you need to do is decrease the flow by 300 ml or so. So once you decrease the flow by 300 ml in an adults, what will happen? The saturation will, suppose saturation improves, that means there was a recirculation because of the flow. If saturation remains the same, then that means that you don't require that much high of flow. If there's no recirculation at all, when you decrease the RPM or when you decrease the flow, the saturation will also decrease. So if that is so, that means there is no recirculation because of the flow. So if your saturation improves, then keeps on coming down on ECMO flow till the time your saturation start dropping, and then keep a one level above that the flow. So that is the way you can define the problem. Second is the catheter position. You have to see if the double lumen cannula is there, the chance of recirculation is going to be less in double lumen cannula if it is properly placed. But any displacement of the cannula, if the cannula comes up a bit, then it can lead to recirculation. So the cannula position is most important when it is the double lumen cannula. For a two-side cannula, when you are training from femoral vein and jugular, return to jugular vein, the recirculation chances is going to be less. You have to always keep the distance between the two cannula around 10 centimeter. In the adult, you should maintain that much distance in the patient cannula. Okay. What is important is any change in the position, especially this is in neonates and pediatrics, any change in the double position of the neck, any change in the lung inflation, any neck edema, when the patient moves, propped up position, lying down position, right lateral, left lateral, all that change in the position can cause recirculation if the patient is on double lumen cannula, and especially in the pediatrics and neonates, this happens. Usually you don't see that commonly in adults, but most commonly it can be seen. So you have to always be mindful when you are giving the position to them, and you have to be watchful about it. And whenever there's a recirculation, you can always see the change of position, and you can see whether that helps. Now, how will you diagnose the catheter position? By an ultrasound or with the help of XHS. You can see the position of the cannula, and you have to change the position of the cannula. If nothing is helping, as I told you, you have to convert to VVB. So this is what happens if the cannula gets pulled up a bit. Instead of the last hole which comes in the IVC, if it comes to the RA, then it can give rise to recirculation. But the same blood is going to go back to the drainage cannula, so that can give rise to recirculation. Another factor is which decides is your cardiac output and RA size. So if your cardiac output increases, if you are the heart rate is too much high and the tricuspid valve opening time is less, then that can lead to recirculation. So when there's an arrhythmia like an AF with fast VR, when the heart rate goes over 180, then the saturation is going to drop because of the recirculation. Or when there's an absolute cardiac stensil, when the tricuspid valve is not opening at all. So whatever the blood comes from the retinal cannula goes back to the drainage cannula. There's 100% recirculation if there's a cardiac stensil. Okay. So cardiac, the recirculation will depend on the cardiac output, the heart rate, the stroke volumes. If there's a severe dehydration, the RA is empty, again the recirculation is going to be more, because whatever the blood comes from the return cannula, the drainage cannula is going to suck out that blood. Okay. So these are the different things which can give us to recirculation. So first is recirculation management is going to be, you always try to correct the position, correct the cannula position, correct the patient position. If nothing is helping, then probably we will have to convert to VVB ECMO. So in that, as I told you, shown in the previous figure, you have to drain from one femoral vein, which is going up to IVC, from the SVC through via jugular, and then retinal cannula from another femoral vein, which goes up to the RA, and that is where what you do. Ideally is cephalate cannulation, but usually nobody is doing cephalate cannulation. Okay. So this is the way you manage. Then from one femoral vein which goes up to IVC, this is going to go to RA, and this is going to be in the SVC. And the last part of the talk is going to be weaning from VV ECMO. How will you wean the patient from any ECMO? So you can start thinking weaning when the parameters are made. So if the patient is maintaining good saturation on the minimal ECMO flow, the pump flow is around 3 liters per minute in adults. Okay, so if that is on that 3 to 3.5 liters, if it is maintaining good saturation, or say saturation about 95, then you can start coming down on the ECMO FID. Okay, you always maintain flow of more than 3 liters to prevent the clot, so that you don't have to increase the heparinization. And anyway, your VV ECMO weaning is not dependent on the flow; it depends on your gas exchange. So it depends on the FI2 and sweep gas. Now, there are two methods of weaning. One center, most of the centers, in fact, US and India, they decrease the FiO2 first and then the sweep gas, and that is the way they do weaning. Some centers, especially the centers from Australia, they prefer to directly come down the sweep gas rather than coming down the FiO2. The logic is basically once the lung starts improving, the oxygenation is not a problem. Usually, a CO2 is a problem. So, if you decrease the sweep gas and if you maintain CO2, it's going to maintain the PO2 also. That's the basic logic. Trial of usually we do is we stop the sweep gas completely. We disconnect the oxygen pipeline or a gas pipeline from the oxygenator. So there's no gas exchange is occurring. The blood is flowing. The same blood, the blood which is coming from the venous side or drainage tube, same blood is going back to the return side without doing any gas exchange from the outside. If he tolerates that trial of for a long time, then we can think of decongestion. Now, this trial of we can keep it for a long time, unlike your VA ECMO trial of which we usually keep for 1 to 2 hours only. This trial of you can keep even up to 8 hours, 12 hours, or 24 hours also, because you are not changing the flow. So your target of ACT does not change, and there is no risk of additional risk of clots and bleeding. Okay. Decongestion again, once you maintain that, you can think of decongestion. Decongestion is again a simple procedure. You have to just pull the cannula out and take a pulse string suture or a horizontal matrix suture, unless you have done a cannulation with the open technique. Otherwise, you can just pull the cannula out and give a pressure and take a skin stitch. That is fine. You don't have to repair the artery like you do in a VA. So these are the parameters for considering the patient for VVA, weaning from the VVA ECMO. If the patient is intubated and if the patient is not intubated and on VVA ECMO, these are the parameters where you can think. So lung compliance improves, the X-ray is improving, the end CO2, tidal CO2 starts coming up. So that becomes a good sign that the lung has started excreting the CO2. ABG with the rest ventilator settings with the PO2 more than 70, PCO2 less than 40, pH of 7.35. Saturation 95 and above, maintain tissue perfusion, then in that case, you can think the patient to be weaned off from the ECMO. If the patient, neonatal patient, then you have to always take to the pulmonary hypertension, and it has to be resolved. Okay. VV ECMO, non-intubated patient, if the PO2 is more than 70, PCO2 less than 40, pH 7.35, same, but the nasal oxygen or mass oxygen less than 6 liters, or if this patient is on HFNC, then with the less than 40 liters of per minute of flow and FiO2 less than 30%. In that, you can consider weaning the patient from ECMO. Suppose you get a hypoxemia during ECMO, how will you approach it? First, always look at the tube color. If both the tube colors are same, both are dark, that means there is a gas flow failure. If both are bright, it means there is recirculation. If that is not that, look at the technical issues, pulse oximeter, whether it is connected properly or no. Look at the flow, whether the flow is same or flow has decreased, because when the flow is decreased, the saturation is going to come down. So look at the flow. If it is decreased, look at the cause for the why the flow has decreased. Look for the demands, whether the patient is going to high metabolic state, so fever, restlessness, sepsis. Look at the delta pressures and see what is, if the delta pressure is high, look at the post-oxygenated ABG. If the post-oxygenated ABG is, the PO2 is less than 150, then you have to think of changing the oxygenator and get an X-ray, and if you don't, to see the parenchymal worsening. If there's anything which leads to parenchymal worsening. Okay. So the take-home message is assess and choose the patient wisely and early. Choose mode of ECMO which organs you need to support. Ensure adequate tissue perfusion, that is most important. Always remember, you don't hurt the patients. Be persistent, it is going to be a matter of time. And the most important, the key to success remains in the time of initiation of ECMO. At what time you initiated ECMO. If you are initiating ECMO too late, then the outcome is usually not good. Okay. But always remember that ECMO is a tool to delay inevitable. ECMO is to prolong the life and not to prolong the death. That is always, you should always keep in mind. So a short tips for VV ECMO: inotropic support is not contraindication. Maintain venous pressure, so give good fluids. Keep recirculation less than 30%. If you require, convert into a VV ECMO. Control the cardiac output to improve oxygenation. Pull the patient to improve the oxygenation. Maintain hematocrit to improve the oxygenation. So you try everything, but most importantly, keep rest to the lungs. Your intention of putting the patient on ECMO is not to improve the oxygenation only. Your intention is to give rest to the lung. So always try to see that you give rest to the lungs. You try everything else, but give rest to the lungs. Okay. So if there's a hypoxemia, correct the cause, increase the supply, decrease the demand. ECMO troubleshooting is balance of adequacy and safety. So that is always you have to remember. If you are maintaining adequacy, but if you lose safety, that is not pardonable. So always remember you have to maintain the balance of adequacy and safety. And always remember you have to put an effort to improve the lung function from day one. So don't definitely give rest to the lungs, but don't make it lazy. So the patient, you put the patient on VV ECMO, you forget the patient for 15 days in the lung, you don't make any efforts for the lungs to improve, then that won't help. That will increase the number of days of ECMO, and usually the outcome is not good. Okay. So the last word is keep patients alive, and do not harm the patients. Thank you.
Thanks for the extensive knowledge sharing on VV ECMO, sir. I can see one question in the chat box from Dr. Muthukumar Rajagopalan. How frequently should we do ACT or any coagulation tests in VV ECMO? Does it differ between patients?
Depending on the ACT, usually we target ACT to 160 to 180. So if your readings are remaining consistent in that range, usually we do 4 hourly. But if there's a variation, your readings are not either too high or less, then probably we might do 1 hourly also. But usually 4 hourly is the standard.
Okay, sir. And again, ECMO topic being very nervous to most of us. So they have requested the videos to be shared. As everyone agreed, we will share the videos shortly. Kindly give us some time. Thanks, Pranay sir, for sparing your time and sharing your knowledge, sir. Thanks for joining us, sir. Thank you.
Thank you. Thank you.
Moving on to the final topic of the day and online lectures. I invite Dr. Arpan Chakraborty, sir. He is a senior consultant, critical care and ECMO physician at Apollo Multispecialty Hospital, Kolkata. And he was the past president of ECMO Society of India. And he has numerous publications to his names. On areas of interest or ECPR, that is the topic we are going to speak now. That is one of his areas of interest. So over to you, Dr. Arpan, sir. Thanks for joining us. Over to you, sir. We are able to see your screens clearly.
Yeah. Hope I am audible also.
Yes, sir. You're audible clearly, sir. Over to you, sir.
My video is flickering, so I'm just closing that video. Okay.
Yeah, sir. Okay, sir.
So after these lectures of ECMO and VV ECMO and VA ECMO, last part of the thing is the ECPR. Now, obviously, I don't have any interest of conflict or any financial disclosures. So what is an ECPR? This is basically nothing but when you do your ECMO and the conventional CPR side by side. That is known as ECPR. So it is an emergency initiation of ECMO during refractory cardiac arrest. Now, you can perform ECPR in the emergency itself. You can do it in the ICU. You can do in the cath lab. You can do in any pre-hospital setting like out of hospital cardiac arrest. And your purpose is to augment the end organ perfusion and hemodynamics during that cardiac arrest. And that's why you buy some time to get the ROSC done, like in cases of pulmonary embolism, MI, any drug overdose situations. So ECPR is destined or it is directed towards this kind of conditions. Now, how do you select which patient you will go for the ECPR? For ECPR, we considered a little bit younger age because of the reversibility of the thing, and initial rhythm of VFVT, which is non-shockable rhythm, is the accepted one. And your chest compressions started within 10 minutes of arrest, so that a good quality of CPR that guy has received for the adequate brain protection. Any kind of refractory arrest which has happened more than 30 minutes, no ROSC despite standard CPR, no major comorbidities, and if the cases are for the hypothermia, intoxication, ACS, so these are the patients to be selected initially for the ECPR. And if there is a chain of survival for the ECPR to be done, then you know what, there are some lay rescuers with the out of hospital cardiac arrest. You go for emergency medical system, then you go for go to emergency department, you go to cath lab and in ICU. So this is chain of thing we follow in ECPR. Obviously, the motto is to keep calm and save the brain. That is our thing. And you have a golden hour of ECPR also. Like as you start ECPR early, you will get a very good outcome. As it crosses in 60 minutes or 1 hour, the outcome goes down very significantly. So what our ELSO tells us about the ECPR, that is the AHA guidelines for CPR recommends the consideration of ECMO to aid CPR in patients who have easily reversible event, have an excellent CPR. So mostly the MI, mostly the pulmonary embolism, mostly the poisoning with some shockable rhythm are probably the excellent candidates. Now, in all contraindications to ECMO, the advanced stage, having known comorbidities, are all applicable to the ECPR event. And the futility is also important. The unsuccessful CPR for 5 to 30 minutes, no return response, it might be a futile exercise to put the patient on ECPR. Sometimes, because of logistic reason, we might need to put the patient on ECMO even after 1 hour of CPR or the prolonged CPR. If you think that in between conventional CPR, which has been done, was very adequate and very good quality of CPR, and it has been able to maintain a good perfusion and metabolic support. Now, cannulation, obviously, we know we do cannulate by three means, by centrally, by percutaneous, and then mixed therapy. Now, central cannulations are mainly for the CTVS ICU, where your chest is open or chest is recently closed. The patient got arrested in the ICU, and you open the chest and go on bypass without any delay. So that is a very good central ECMO exercise or central ECPR you can do. But most of the time, the patient's arrest happen either out of hospital cardiac arrest or in the emergency or in the cath lab where chest is not open, or then you need a surgeon to open the chest where it is not there. So what you are going to do, you have to do a percutaneous cannulation, the peripheral cannulation. Now, peripheral cannulation, the ideal situation is go for the femoral cannulation. Now, what we do, we take help of surgeon if we don't have a USD machine over there to locate the vessels, or you take the help of the surgeon to cut down at that point of time in the ongoing CPR. You can see the vessel and can directly cannulate because the vessels, the artery is very much constricted because of the high inotropes, because of the shock stage, and the vein is tremendously dilated. So you don't know where you have punctured. Sometimes some previously placed lines, like in cath lab, you have a venous sheath or an arterial sheath, which you can exchange very easily. So these are the patients where these are the ways of cannulation in ECPR. In pediatric patients, the patients are more than 15 kg, or you are doing it in the specialized areas of cath lab, the percutaneous cannulation can be done. But in smaller childs, less than 15 kg, because the size matters at the stage of the hurry of that CPR is going on, you cannot attempt this percutaneous cannulation peripherally. Now, you need an ECPR team which consists of ECMO nurses, ECMO perfusionists, ECMO physicians, and you have some echo, some USG machine, and the C-arm guidance is required. So what we do is, whenever a cardiac arrest happens, we have done the conventional CPR more than 10 minutes, you just call an ECMO code ECMO team alerted, inclusion criteria like ECMO team arrived, set up femoral arterial vessels and venous access catheters, you have done, and heparinization, cannulation, and initiation ECMO you have done already. Now, what are you going to do? Establishing an ECMO flow after that, and give some good flow. Now, after establishing a good flow, if you got ROSC and if you have an adequate aortic valve opening, you just continue the ECMO to run. But if you have a poor aortic valve opening, or if you have a chance of LV getting distended, so you have to take a call for the LV distension, LV decompression strategies. Now, there is another aspect where ECPR is very commonly performed. That is the ECPR in hypothermia. Not very much common in our country, but in the Western country where the temperature is very much extreme, and in the seasons where the temperature goes down further, there is a chance of severe persistent hypothermia. And people have done ECPR in these cases. But one thing you have to keep in mind, if your potassium level is more than 12, they don't start ECPR on this patient. But if your potassium is less than 10, ECPR is done because there is a chance of coming out. Now, what I was talking earlier, that open, semi-open, and percutaneous method are the three methods you can put the patient on ECMO. And look at the patient. This is a case where we are doing ECPR. We have put one guide where is the medially in the groin to the vein. We have two sheaths. One sheath is going towards the head, the femoral artery, and this is a retrograde sheath which is placed in the same artery in the retrograde fashion. So this is the prerequisite for putting the cannulas, and you can easily put serially dilate this sheath and to put an arterial line, arterial cannula. And what we are exactly doing, we are just dilating the femoral sheath, which is going towards the head, or it's a kind of antegrade sheath, and putting the your ECMO cannula. And this is ultimately, this happens with that thing. It's a case of massive pulmonary embolism, who was actually getting thrombolized, but got arrested in between. We had to put him on ECMO, and this is the configuration we have done. This is the femoral peripheral veno-arterial ECMO, where we have put the femoral artery in the groin and femoral vein, and this is the distal percussion sheath we have put. Now, this is another case which came to our emergency with the stuck mitral valve in the cardiogenic shock and got arrested. We somehow did the CPR, didn't get a good ROSC, and then we put the patient on ECMO. This is a venous cannula we have put to the right groin. This is the arterial cannula we put in the left groin, and later on we put the distal percussion cannula. So this is the way we do the ECPR. And I was talking about this. This has happened in the CT ICU, where the recently done CABG had got an arrest, and we had to open the chest and put the patient on ECMO. And with that, this cannula is central, this the femoral, there is a right atrium and the aorta with the pulmonary artery vent. Now, you have a lot of advantages and disadvantages of different things. Surgical, you need a surgeon. That is the most, the surgeons are not always there at the time of need. But you have to know the percutaneous thing. You have the bleeding is much more with the surgical thing, but not much with the percutaneous one. Now, one thing you have to keep in mind after getting the cannulas, you have to correctly connect the arterial and venous cannula. That is one. Corresponding link should be checked, because if it goes the opposite, it's a catastrophic thing will happen. Total body hypothermia can be done. Cooling should be achieved applying ice to the head during the CPR and 48 hours, 8 to 72 hours after ECMO cannulation. Neurological examination with the discontinuation of neuromuscular blocking agents after hemodynamic instability, and evaluation of LA hypertension should be done if there is any LA venting is required or not. Regarding the limb ischemia of the distal percussion cannula, one important advice or the way of practice we don't go for immediate distal percussion cannula, because this takes time to put the distal percussion cannula at that point of hurry, and don't try to practice it. You just put two cannulas, one venous and arterial, and go on ECMO. You can put your distal percussion cannula after that also. So you don't spend time to put on the distal percussion cannula. In this patient, we have put the patient on ECMO, putting two cannulas, and we didn't get a good distal percussion thing. And later on, we cannulated the posterior tibial artery with a small 5 French cannula to put the limb perfuse. This is a case of ECPR. You can see there's a progressive valvular distension is happening, and you're hardly any systole diastole gap is there. And if you can see that look at the LV, it is getting distended on ECMO. In every beat, your aortic valve is not opening. So very carefully, you just look at the videos. Your LV is getting distended, and there is no pulse pressure seen. So this is the thing we have to prevent. If this happens, you have to go for a LV distension, the management of LV distension. Now, if you see this, what happens if you don't take care of this LV distension? Actually, this thing happens. This is just a LV clot and aortic valve thrombus, which is formed because of the prolonged LV distension, and the clot is just beneath the aortic valve and the LV. So this is very thing we have to keep in mind. Have to go for a decompression of left ventricle. Now, how do you manage the LV distension in ECPR patients? The most commonly used thing is the balloon, which gives some amount of pulsatility in your opening of the aortic valve, or you can puncture your intraarterial septum to put a large PFO that can vent your left side or the right side. Now, many times we put a separate cannula, in the LA to get it drained in the drainage cannula also. Now, cerebral saturation has to be monitored, because we are actually, when a femoral VA ECMO is a retrograde flow, whether the cerebral circulation is adequate or not is remain a question. The usual trend is to monitor clinically by thorough neurological. If the patient is awake, there is no problem. But if you have adequacy of cerebral perfusion, you have to see, you have to put a NIRS also at that point of time. There are a few trials, which is TIER trial, which shows a 55% survival, but during same J2 study, which showed only a survival of 27.2%. So there is a variable number of success rates in ECPR in different strategies. And if you see the LSM registry, neonatal is 42%, and with the adult of 29%. It is again 30% with the adult ECPR survival rate. So it's quite a bit improved from before, because you have to understand that the patients who are getting ECPR actually would not have been alive without doing that ECPR. Now, I just share one case, which is a 52-year-old male smoker, type 2 PM, present with acute intravenous in another hospital, where primary angioplasty attempted, but RCA origin could not be engaged. Meanwhile, he became hypotensive, started on NORAD. His pH was 7.11 with cold periphery. So shifted to our center after 18 hours, and features of cardiogenic shock, AKI, sudden bradycardia hypotension, had a cardiac arrest, intubated and ventilated, and lost the rhythm, still hypotensive, NORAD, vasopressin, adrenaline lactate. So this usual scenario of severe cardiogenic shock. So we rescued him on ECMO at the emergency because he was losing his rhythm. And you can see the RV, which is dilated. If you see, this is the LV, which is bit dilated. This is the RV. Look at the RV. Free wall is again very much dilated, and this is a classical case of RV infarct leading to the cardiac shock. And if you measure the taps, it is less than 8, and there is hardly any movement of the RV free wall. In that patient, we put the femoral percutaneous veno-arterial ECMO in the emergency. We got some flow, 3.28 is the flow at the 3215 RPM. And we put that NIRS leads in the limbs. We found the one limb is like your in the left limb, the perfusion was bad, and the right limb was fine. So we had to move to the why it is happening. The distal perfusion canal was not appropriate, so we had to change it to the posterior artery. And then we found that, and checking the distal perfusion, we can see the artery by normal your USG probe, flow probe, and you can see the flow, which is non-pulsatile because of the distal perfusion is going, which is non-pulsatile flow. And you can measure the checking the flow in the distal limb, and you see after doing that, you've got some amount of flow on the both sides, which is to some extent equal. Now, after that, you see to see the adequacy of tissue perfusion. Patient might should pass good urine output, good lactate clearance should have happened, and if you have some facilities of mixed venous saturation to calculate, you can do it. And your target ACT is 180 to 200, and ACT is to 1.5 to 2 times. This is the maintenance. This is the patient on the day 3 is getting awake, and though his kidney got shut down, we are he's on dialysis going on, and this is the X-ray. After getting some amount of pulmonary edema in the lung, we found a saturation of very low on the right hand, and we demonstrated Harlequin phenomena in this patient because we put a CT angiogram to see what happened to the coronaries. Then we see the dye flow which goes to the arch only. It didn't go to the base of the heart. So some amount of Harlequin was happening, but it settled down with the intermittent dialysis and fluid taking out. On the day 6 of ECMO, we got some amount of improvement in the heart function with the millinode and touch of NORAD. And if you see the heart, which was distended, got smaller and started good function. Now, regarding the weaning, something we have to tell that hepatic function should have been recovered before any attempt of weaning for the patients, irrespective of the findings on the cardiac assessment. It is an unusual attempt. It should not be attempted up before 72 hours of the ECMO implantation. The mean duration of support was at least 5 days, and not necessary to. You can wait. You should not wait for the renal thing to come, because you can support the kidney with the regular dialysis, but you have to wait for the liver function to come up. Now, weaning compatible for the myocardial recovery, MAP more than 60, pulsatile waveform, lactate less than 2, PO2 ratio lung should be fine 200, and LVEF 20%. VTI more than 12 and TAPC more than 12. Then you start the weaning. And then you put a bridge before the weaning. That bridge is nothing but a connection between your venous and arterial cannula. And if you see the weaning, you come down on ECMO flow by 0.3 to 0.5 liter per minute, increments for 5 minutes at each time. The flow is reduced to 1.5, but no less than idle flow. And you keep on checking the MAP. Regularly correct your checking your aortic VTI and see how much your aortic VTI is function, how much your aortic VTI is there. Now, predicting success, you have to keep in mind that while coming down on ECMO flow, the MAP drops to 40 or CVP rise to 20. Oxygen saturation also drops to 80%. So you have to go back to the previous flow and you have to abandon the weaning trial. And you wait for 48 hours, then come on the weaning. Now, decannulation, we do take out your arterial cannula surgically, and femoral venous cannula, which is taken down by usually removed by percutaneous technique. And if there is significant pulmonary dysfunction persistent in few patients, you have to transition the VA ECMO to the VV ECMO. Now, this is the same patient, the rehab and follow-up is doing fine, and you have to follow their thing till they are good friends with you. So, thanking you with the take-home message that ECPR, which is starting after 20 minutes of CPR with AED, the goal is to be within 60 minutes of cardiac arrest in the ECPR should be started, and it can be prolonged if a good CPR has been done for neuroprotection. And you can select your patients, mixed or percutaneous, whatever you want, what you know best, you should do at that point of time. And pre-hospital ECPR, though not much common in India, not yet started, good results also need to be confirmed. So thank you. Over to you.
Thanks a lot for that interesting upcoming tool for resuscitating patients going for cardiac arrest, sir. So in your experience, how many ECPR you have initiated, sir?
I think I have initiated almost 20 ECPRs.
Great, sir.
So outcome is not very good. Okay, but I think around 30%. My thing is matching with the also. Yeah, almost 30% patient went home, but the other 14 patients, like I think 5-6 patients went home, and other 14 patients who didn't go home, almost 90% of them had cerebral issues.
Yes, sir. And how do you manage the finance issues, like taking such a hard decision while the patient is undergoing CPR, sir?
It's difficult, but I'm telling you, the situations are mostly happened in the ICU. So it was easy to demonstrate that this patient was not doing well. So we had to put him on this thing and giving some discounts after that if they die. And these are the very common things. But otherwise, it's difficult to manage the finances part. So what you can do one thing that some circuits you can make it with a regular oxygenator for the ECPR. You just put the patient on with the normal oxygenator, put the patient on ECMO and see how whether he's getting awake or things are fine. And then you change the oxygenator to the normal oxygenator, the regular ECMO oxygenator. If you smell that the thing is going to be long lasting and patient might be doing well and patient can pay after that. So that is one way you can reduce the cost of things at that point of time. If you have some query in your mind that relatives might not pay or you are not being able to explain them at that point of need.
Agreed, sir. And a compliment from Dr. Madhavan. Excellent presentation, sir. Thank you. That was in the chat box, sir. So thanks once again for sharing your valuable time in spite of busy schedule, sir. Thanks for joining us, sir. Thank you, sir.
Thank you.
And we come to end of the online lectures, CME. So we break here, and 60 of the delegates who have registered for workshop, we are eager to welcome you and discuss with you this 18th Sunday morning, 7:30. So the details and other directions for workshop would be given in the group we have created. And one more question. Arpan sir, are you available there, sir? Okay, so I will take up the question. Can ECPR be started on outside hospitals? Yes, there are possibilities and have been reports in abroad where they have started ECPR in a railway platform. Just like what we have AED kits nowadays in all the malls, railway junctions. Whenever I attended many conferences, ECMO conferences, they do tell that in future we would have ECMO kit in the malls and railway stations and wherever the public gatherings are there. And so whenever the patient goes for arrest, there would be a day where we would be able to initiate ECPR, I mean ECMO, during cardiac arrest scenario, like in public places, that is outside hospitals. The way Dr. Arpan sir presented like 20 ECPRs he have initiated, I don't think the day would be very far from now. So we hope for the best for our future. So coming back to the group for the delegates for workshop, those who have not been enrolled in the group yet, please let us know. We'll be giving some instructions and directions, and we request few answers from you to organize better. So we break here, and we promise you that we will share we'll be sharing the videos shortly. And thanks for joining us. And this is our second edition of SIP online lectures coming to an end. We will meet you again next year, SIP 2024. Probable theme for the next year would be on probably infectious diseases. We will come up with a better subject and knowledge sharing. Thanks everyone for joining us. Thank you. Good night.